Hello, good evening, everyone. So I hope everyone is doing well on a Saturday evening. All right. Hello mga B. Hello sa ating mga nandito sa Zoom at sa ating mga nanonood sa portal. Hello. Ito lang ha. Okay. So again, make sure na hindi nyo na-open ang inyong mga videos kung hindi nyo gustong i-open. All right. So hello mga B. It's again today we'll have Pedia, summary lecture, and Quizmaster. But before we start, let's say a little prayer. Let's put ourselves in the holy presence of the Lord. In the name of the Father, the Son, the Holy Spirit. Amen. Heavenly Father, thank you for another blessed day. As our students, featured doctor, listen to the summary lecture and answer today's quiz. Keep them, sustain them, and enlighten them. Send in your Holy Spirit to pacify their worried minds so they can focus on the task ahead. Keep their families and loved ones safe, Lord. Grant them the utmost understanding of all their ordeals they are going through, and may they find peace in knowing that you are blessing and guiding them constantly. This we ask through Jesus' name. Amen. In the name of the Father, the Son, the Holy Spirit. Amen. Doc Ian is here already. Pero Doc Ian, mag-show lang ako ng isang video, no, na pang-pa-inspire bago tayo mag-summary lecture, no, to inspire you guys. Wait lang. So this is one of the send-off videos na ginawa ng inyong mga mentors and mother goose. So we will show this para malaman nyo na a lot of people, no, do care for you guys, no? Ayan. So sana ma-inspire kayo. Pinaghirapan to ng mga mentors nyo at mga mother goose. Alright? So this is our send-off video last October 2021. So kaya ito yung show ko kasi ito lang yung nandito ako. Okay, go, push!
So I only wish the best for all of you.
So good luck, everyone. We're all praying for you, and we really hope that that we will soon meet you in the clinics as physicians in the future. Good luck, everyone. Lots of love from me and your Mother Goose MM.
Congratulations. With all due heart. Marami pong salamat and God bless everyone. Thank you mga anakis.
Ayan, medyo marami pala akong sayaw-sayaw at medyo healthy ako ng mga panahon na yan. Hello? Asa na ba tayo? Ayan, so some announcements before we start, no? Your mentorship, no? Thank you to your mentors na gumawa ng video na yun. The mentorship program is still ongoing. If you're interested to join the program, again, it's absolutely free. For those who still want to join, to have a mentor, please message your Mother Goose together with your mentorship profile form. Second is Top Notch Genesis is to be launched. Okay, the details of Top Notch Genesis can be found in the Top Notch FB page and also in your Viber groups. So if you have friends na clerks or interns, please do let them know that the Genesis program, no, this on its third year, will commence, no, on September 15, and registration. The registration date will start on Sunday. Okay. Also, your practice test in Pedia is ongoing proofreading. Your practice test too. So, watch out for that. Sasabihan namin kayo pag Gina at nandiyan na ang inyong mga practice test. Alright? So, game na. Game na tayo. Our lecture for today, no, ang walang kapaguran. 3 days siyang nag-on-site, no, hanggang kanina. Your Pedia teacher, co-author of the Pedia Platinum, had his residency at the Philippine Children's Medical Center, a graduate of UP-PGH, and the CEO na ba, Doc E? CEO of the
COO pa lang, COO pa lang.
Child of Owner.
Child of the owner.
Of the De Vera Medical Clinic in Isabela. So if you're in Isabela, tapos pumasa na kayo ng boards, no, kung gusto nyo mag-practice, pwede nyong message si Doc Ian. Everybody, let's give a warm round of applause. Dr. Adrian Salvador M. De Vera. Welcome, Doc Ian, no, to the virtual.
Bye. Good evening.
Good evening.
Si Doc Broly.
Good evening.
Yeah. I'll be giving the corrections clarifications later after the lecture of Ian. Mga ilang oras ka ba? 1.5?
Kaya. Bahales pa.
Sige. Message mo lang ako niya pag game na ako. Tapos, regarding the Pedia Practice Test 2, we will release them, okay? As soon as matapos yung Quizmasters ninyo. May final check na ginawa regarding the questions. Kung napapansin nyo guys, bawas na yung mga corrections, mistakes na nandoon sa practice test nyo dahil isang katutak ang taong involved ngayon dyan. So medyo nagkaroon sila ng final checking pa regarding practice test 2 ng Pedia. We will release it by today. Sinabihan ko na. Okay? As soon as matapos yung Quizmaster, go na. Ian, your show. Ninya.
Alright, again, let's welcome Dr. Ian De Vera. Go, Doc Ian. The floor is yours.
Alright. Malinaw ba? Naririnig ako?
Yes, Doc.
Wait lang. Hindi ako makapag-share ng screen. Alright. Okay. Kita yung screen ko? Yung Pedia? Alright. Alright guys, so wow, ang ganda ng video, no? Buhay na buhay. Nagkaroon ako ng energy ulit kahit medyo pagod na. Alright, so guys,
Summary lecture for pediatrics. Most of this naturo na namin the past few days. I know you guys have been studying pedia. And for those who attended the lecture, a lot of this, alam na natin na dapat. Pero we'll be giving a summary para mas madali niyong maalala, para mas magkaroon tayo ng recall dun sa mga most important concepts natin for pedia. Alright? Okay. Let's start. Neonatology, again, remember your EINC, remember the steps, remember your chronologic order, and remember why you do it. Okay? You have to dry the baby systematically first, 30 seconds, 5 seconds each. Face, head, trunk, back, arms, legs, to prevent hypothermia and also to stimulate the baby to cry, which is very important para huminga yung baby for respiration. Next is your skin to skin. Huwag kakalimutan, mauunang skin to skin bago cord clamping. Again, magde-delay ka muna, except for cesarean section. Pag cesarean section, magpapalit itong dalawang ito. Mauuna yung cord clamping bago skin to skin. But for normal delivery, mauuna yung skin to skin. Duration is 30 to 60 minutes. Okay, 30 to 60 minutes. In the board exam again, the better answer would be 30. Okay? Sabi ng guidelines until after the first full breastfeed. Remember that this is for transfer of good bacteria, thermoregulation, which is very important, and it also increases breastfeeding success. Cord clamping is 1 to 3 minutes or pulsation stops, whichever comes first. Please do not forget that. It prevents anemia in both full term and preterm, but it also prevents brain hemorrhage, IVH in preterm. Non-separation of the mother and baby is also very important. It increases success and for thermoregulation. Okay? Dagdag nyo pa sa EINC, hindi ko yata naituro during the lecture, kailan pinapaliguan si baby. It's either 6 hours, yun yung lumang guidelines. Okay, baka yun kasi lumabas sa questions, 6 hours. Or ngayon, ang mas bago ng guidelines is after 24 hours. Okay, after 24 hours bago pinapaliguan si baby. Routine suctioning is not done. Delivery room temp is 25 to 28. Thermoregulated is 36.5 to 37.5. Low birth weight is less than 2,500 grams. Kasi pag very low, it's 1.5. Extremely low is 1,000. Late preterm is 34 to less than 37. SGA, remember the magic number 10. For LGA, it's 90th. And again, there are a lot of complications pag maliit yung baby and pag sobrang laki. Expected complications for LGA, remember birth injury, polycythemia, hypoglycemia, and jaundice. All right, resuscitation. Okay, detailed, very detailed and discussed to during your video lectures. Your priority is again always airway. Okay, airway, breathing, then circulation. Remember the ventilatory corrective steps, Mr. Sopa. Check the mask, reposition the airway, suction, open the mouth. Baka kailangan nyo magtaas ng pressure, your PIP. And if hindi pa rin gumana, check if you need alternative airway, meaning intubation. Okay? When you do chest compressions, kailan? Pag yung heart rate bumagsak ng less than 60 seconds, 60 beats per minute. Upon suctioning the baby grimace, what is your APGAR score for reflex irritability? Sabi natin, ang grimace na salita, ang score niyan is 1. Huwag kakalimutan. Alright. Again, for newborn screening-related diseases, binanggit na rin natin to. Remember, galactosemia, kidney, liver, brain. Abrupt ang onset, mabilis. PKU, brain lang, mabagal, musty odor. MSUD, mabango yung amoy ni baby, mabango yung ihi niya. Brain lang din, puro neurologic yan, and usually early in onset. So sa tatlong to, si PKU yung gradual, mabagal. G6PD presents with hemolysis, hemolytic anemia, usually pag na-trigger ng oxidative stress. So may mga bawal silang kainin katulad ng fava beans. CAH, maraming types ng CAH. Ang pinaka-common at sana yun yung tatanungin sa exam, it's your 21 hydroxylase deficiency. Normal at birth, ambiguous genitalia, but more importantly, it is sexual and somatic precocity, hyponat, hyper-K, and hypoglycemia. Again, go back dun sa chart, guys. Yung cholesterol papunta dun sa androgens, estrogens, papunta dun sa mineralocorticoids, saka dun sa glucocorticoid. Okay? CH, sabi natin, global developmental delay, macroglossia, huwag kakalimutan ang prolonged jaundice at delayed tooth eruption. Kaput versus subgaleal versus cephal. Okay? Superficial is your kaput, nasa scalp lang siya. Cephalomatoma is subperiosteal, sa ilalim ng buto. Okay, periosteum, yung outer layer ng buto. Subgaleal is below the aponeurosis, rupture of your emissary veins. Dagdag niyo pa siguro dito, it's usually associated pag yung vacuum delivery. Okay? Tapos, characteristics. Okay? Caput crosses the suture line. Skin color changes dahil mababaw siya. Cephal does not cross, no discoloration. Subgaleal, kumakalat sa batok, kumakalat sa muka. Pag kumakalat-kalat yan, that is subgaleal. Okay? Caput resolves in 2 to 3 days, the rest in 2 to 3 weeks. Mas matagal. Caput does not increase. Okay? Pag lumalaki yan, hindi yan caput. Malamang cephal or subgaleal. Surgical conditions, early onset, frothing. Okay, giveaway yan. Frothing, exacerbated by feeding. Pag naglagay ka ng NGT, hindi siya nagpa-pass down. Again, the most common type is your type C. This is your TEF, esophageal atresia with TEF. Ano, again, type C. Remember, okay, esophagus ends in the blind pouch with a distal TEF. Blind pouch ng esophagus, distal TEF. Okay? Difficulty of breathing, scaphoid abdomen. Okay? Ang bata, pag nahihirapang huminga, lumalaki yung tiyan. Ito, scaphoid siya. Okay? Paradoxical. Tapos, bowel sounds. Pag nag-auscultate on the chest, think of your congenital diaphragmatic hernia. Okay? The most common type is your Bokdalek. Again, madaling tandaan sa anong location. Bokdalek hernia, back the left. Okay? Nasa likod, posterior, nasa left. Okay? Eviscerated content, may balot, may sac, midline. Associated with other anomalies dahil nga midline siya. Think of omphalocele. Okay? Stormy clinical course, binigyan ng pagkain, lalong lumaki yung tiyan at pumangit. Okay? You look for pneumatosis intestinalis on x-ray, and pag may perforation, pneumoperitoneum. This is your necrotizing enterocolitis. Okay? Omphalocele may sac. Ano yung counterpart niya na walang sac? Nakalabas din yung bituka. That is gastroschisis. Okay? Omphalocele is midline, gastroschisis is lateral. All right? Lagi kong sinasabi sa exam or sa review, early onset bilus vomiting, preterm, tapos hindi lumalaki yung tiyan. Okay? Preterm, early onset bilus, may obstruction, pero hindi lumalaki yung tiyan, walang ibang iisipin, this is duodenal atresia. Okay? Remember, urine output in neonates should be present within 24 hours. Meconium should be passed within 24, maximum of 48 hours. Okay? At pag meron kang delayed passage of meconium, what comes to mind? One of your top differentials should be your Hirschsprung's disease. Okay, Hirschsprung's disease, pag delayed passage of meconium. Respiratory conditions in the newborn, sabi ko sa inyo guys, kailangan alam natin itong mga to by heart. Surfactant is present in the fetal lungs by what age of gestation? That is 20 weeks. Okay, detectable in the amniotic fluid at 28 to 32. But the most important figure, mature levels is reached at 35. So anything below 35, you expect that the patient might develop RDS. Surfactant reduces the surface tension. Pag walang surfactant, nagko-collapse yung airway. Okay? Mataas yung tension between the alveoli. So paglabas ng hangin during expiration, nagsasara siya. Cessation of breathing longer than 20 seconds or any duration. Kahit 5 seconds lang kung nagkaroon ka ng cardiopulmonary compromise. 5 seconds pero nag-bradycardia. 5 seconds pero nag-desat. That is what you call severe apnea. Is apnea more common in preterm infants? Yes. The most common cause of idiopathic apnea is prematurity. Okay? Because your respiratory centers are not yet developed. Dok, anong ginagawa pag prematurity na apnea? Hintayin mo lang na lumaki yung bata. Hintayin mo lang na mag-develop yung respiratory centers. Okay? At habang hindi pa siya nagde-develop, you can give your methylxanthines, your theophylline, your caffeine, and aminophylline. Okay? Respiratory distress is more common in preterm. Please remember that, but it is not exclusive. On X-ray, you look for your ground glass opacity, underinflation. Very important. Okay? Bihirang-bihira yung takipnik na underinflated. So ito, underinflation. And atelectasis. Again, bakit underinflated? Bakit atelectasis? Because of collapse. Airway collapse, because of high surface tension, because of the deficiency of surfactant. Okay? Clinical presentation. Early onset. Premature. Grunting. Prominent grunting. Does not respond well to oxygen supplementation because you need your positive and expiratory pressure. And it progresses in the first 3 days. Okay? Management is prevention. Of course, prevent preterm delivery. Give steroids kung talagang hindi ma-prevent. Kung nandiyan na talaga yung RDS, surfactant, and your positive and expiratory pressure. Transient takip niya, on the other hand, is more common in cesarean section delivered baby na full term. Okay, cesarean section, very important. Hyperaerated lungs, prominent vascular markings dahil ang problema nga natin is fluids. Hindi pa niya malabas yung fluids sa kanyang lungs. Early onset, quick recovery. Transient takip niya, benign. Okay, responds well to O2. 1 to 2 LPM pa lang, medyo okay na. Management is supportive. Okay. Jaundice in the newborn. Bilirubin used to determine your management in your Botany chart. Okay, remember Botany chart, you plot there kung kailangan ng phototherapy. Ang ginagamit natin is total. Okay, we're not concerned with the breakdown. We look at the total. The most common cause of jaundice in newborn is physiologic, but remember, this is a diagnosis of exclusion. Which part of your bilirubin crosses the blood-brain barrier? It is lipid-soluble. It is your B1. Okay? Other names for B1, it's indirect, it's unconjugated. So wag pagpapalit-palitin. Okay? So again, indirect bilirubin, unconjugated B1. Okay? Direct is your conjugated, it's your B2. Okay? Treatment for jaundice, most of the time it is indirect, it is phototherapy. The mechanism of action is photoisomerization. Okay? It converts your bilirubin into isomers that are less toxic and more easily excreted. Okay? Duration of physiologic jaundice, for most cases, less than 14 days. Okay? Less than 14 days. Yan yung cutoff natin. Okay, review. Physiologic or pathologic? Jaundice within 24 hours of life, pathologic. More than 12 ang bilirubin, pathologic yan. More than 2 ang direct, pathologic yan. Breastfeeding or breast milk jaundice, this is physiologic. Okay? Mothers O, babies A, Coombs test positive. Ano yan? Pathologic jaundice. Okay? Mothers O, babies A, jaundice on the second day of life, otherwise well, bilirubin is 4, this is physiologic. Okay? Bakit? Huwag malilito. Dok, may setup. May setup tayo. O si mother, A si baby. Kahit may setup yan, kung wala namang hemolysis, hindi lahat ng may setup, hindi lahat ng ABO magkakaroon ng hemolysis. Okay? So kahit may setup, hindi naman nag-jaundice si baby ng pathologic. Okay? Second day yung jaundice niya, well yung baby, tapos 4 lang yung bilirubin, then physiologic pa rin yan. Malinaw? Again, hindi lahat ng may setup magkakaroon ng ABO hemolysis, ABO incompatibility. Breastfeeding is earlier onset. Pathophysiology is inadequate calorie. So on history, yung mother nagbibigay ng milk. Management is, okay, increased feeding. Maximum duration is 2 weeks. Pag breast milk, mas nahuhuli. Mauuna ang F bago M. Okay? 7 days. Lumalabas yan. Glucuronidase. Okay? Sabi nila, unknown, idiopathic. Pero theory, glucuronidase. Duration, it's the only physiologic jaundice that can last more than 3 months. Management may stop. Kung masyadong mataas, mag-stop. Kung hindi masyadong mataas yung bilirubin, pwedeng hindi mag-stop. Okay? Let's now go to nutrition. Okay? Watery, high lactose and protein versus itong isa, creamy, high fat. Yung nauuna, yung watery, siya yung foremilk. Yung nahuhuli dahil malapot siya yung hindmilk. Majority of the calories will be in the hindmilk, kaya nga fat. Diba? Mataas ang calorie ng fat. Tinanong sa exam, protein that triggers your cow's milk allergy. Ano yung nagtitrigger ng cow's milk allergy? It is your casein. Predominant in breast milk, whey or casein. Anong gusto natin? Mas gusto natin mas mataas yung whey. The magic ratio is 3:2. Again, bodybuilders, ang iniinom niyan whey. So that's how I remember it. Absolutely contraindicated in breastfeeding ang galactosemia? Yes. What about TB and breastfeeding? Yes, contraindicated but not absolute. After 2 weeks of appropriate treatment, you may breastfeed. What about HIV? Yes, contraindicated. Pero sabi, if you cannot avoid it, walang ibang pwedeng ipakain sa baby, pwede. Make sure it is exclusive to avoid gastroenteritis, okay? And least duration possible. These 2 qualifiers makes your transmission less, okay? Pag nagkaroon ka ng gastroenteritis, tumataas yung transmission kasi nasisira yung intestinal mucosa. Micronutrients. Difficult to treat eczema, diarrhea, dermatitis, low alkaline phosphatase. This is zinc, acrodermatitis enterohepatica. Rachitic rosary, Harrison's groove, wind-swept deformity, softening of the bones. Yun ang kailangan tandaan. This disease presents with softened bones, vitamin D, rickets, osteomalacia. Scorbutic rosary, irritability, fever, perifollicular hemorrhage, cheilosis, and glossitis. This is your scurvy. Meron din siyang rosary, scorbutic. It is more sharply angulated compared to your rachitic. How do you prevent hemorrhagic disease or your vitamin K deficiency bleeding, VKDB? You give your vitamin K prophylaxis. Okay? Minerals in the breast milk that are dependent in maternal status. Sabi natin gold standard ang breastfeeding. Iilan-ilan lang yung minerals na bumabagsak yung content kapag deficient si mother. Dalawa lang. Vitamin D and iodine. Okay? Breast milk minerals where your fetal stores are enough for the first few months, for the first 6 months. Zinc and iron. Okay? Pathophysiology of malnutrition, severe acute malnutrition. This is what we call reductive adaptation. You try to survive. Okay? The body tries to survive. Hindi priority ang growth and development, hindi priority ang infection control or production of antibodies. Ang priority ng katawan is mabuhay. So, ang tawag doon, reductive adaptation. Measurements used to determine malnutrition. You can check your weight for length or BMI, or you can check your MUAC, mid-upper arm circumference. Okay? Protein energy. Ang kulang is protein. Moon fasces, fatty liver, severe anemia, neurologic deficits. Ano yan? Kwashiorkor. Mas toxic siya kesa sa marasmus. Marasmus presents with old man fasces, walang edema, decreased subcutaneous fat, butot balat yung bata. The hallmark of refeeding syndrome is, ano yan? It's severe hypophosphatemia. What other electrolytes are deranged in refeeding syndrome? Hypo-K, hypomag. Pero ang hallmark, hypophos. Okay? The pathophysiology is your insulin. Because of the surge of insulin, okay, nagkakaroon ng transcellular shift. Kaya bumabagsak yung mga electrolytes. Again, remember, this is the reason why dapat cautious feeding, dahan-dahan ang feeding sa mga severely malnourished patients. Okay so far? Okay lang yung pace natin, guys? Pa-thumbs up naman dyan. Okay lang ba yung pace? Pwede ba sila mag-thumbs up? Hindi sila pwede mag-thumbs up. Okay. Alright. Okay. May mga thumbs up tayo. Let's go to immunization. Okay. Immunization and MC. O, tanong. Can it be given simultaneously? Hep B and varicella? Yes. Varicella and measles. Pneumonia and oral polio. Oral polio and rotavirus. MMR and Japanese encephalitis. Again, wag nang mag-isip. Okay, wag na mag-isip. Pag ang tanong sa inyo, pwede bang ibigay simultaneously on the same visit? Ang sagot, yes. Except for yellow fever and cholera. Okay? Interval, if not given simultaneously. Hep B and pneumonia, may interval ba? Wala. Varicella and chickenpox, parehas na live. Pag parehas na live, kailangan mag-antay ng 4 weeks. Again, ang premise is hindi mo nabigay ng sabay. Pwede siyang sabay. Pero pag nag-varicella ka, tapos hindi mo nabigay yung chickenpox, 4 weeks muna bago ka makapagbigay ng live ulit. Okay? Oral polio and rotavirus, okay lang, wala. Yung 4-week rule, only in live parenteral. Okay? JAP and oral polio, wala. Hib booster, kailan binibigay? Sabi natin, bakuna, 6, 10, 14 weeks. EPI schedule, 6, 10, 14. Booster usually at 1, booster usually at 4. Hib booster is given 6 months from the 3rd dose. So specific yung recommendations dyan. Varicella is given 3 months from the, pakipalitan to, dapat to 1st dose. Okay? Your 2nd dose of varicella is given 3 months from the 1st dose. But again, may asterisk yan. As long as you are able to give it, okay, 4 weeks apart, that is already acceptable. Meaning counted na siya. Okay? So ang Hib natin, example, sabi natin Hib, part of your penta, 6, 10, 14. Kailan ang booster? Dapat after 6 months pa. Eh, Doc, paano kung 6, 10, 14? Tapos nag-booster na ako ng after 4 weeks, 18. Counted na ba yun? Theoretically, yes. Okay? Kasi ang ating bare minimum is 4 weeks for most vaccines. Okay? AGE, most common etiology in children, bata nagtatae walang dugo, rotavirus. Bata nagtatae na may dugo, ang unang iisipin, Shigella. Okay? Irritable, sunken eye, drinks eagerly, very thirsty. No signs, some signs, or severe? Some signs. Management of some signs, treatment plan B, 75 ml per kilogram of your oral rehydrating solution. And your reformulated ORS has a osmolarity of 245. Sodium and glucose ratio is 1:1, 75-75. Okay? And the macronutrient and the micronutrient that we give, okay, for AGE is your zinc. We give it for 2 weeks. Okay? Decreases vomiting, decreases diarrhea, also prevents further episodes of diarrhea in the next 2 to 3 months. So it's also protective. Okay? Let's go to growth and development. Okay? Important things to remember. Birth weight doubles in 4 to 5 months. Pag sa exam, may choices na 6 months, wala yung 4 to 5, tapos 6 months yung nasa choice, pwede rin 6 months. Triples at 12 or on the first birthday. Social smile is 2 to 3 months. Rolling over is 4 to 5 months. Babbling is 6 months. Okay, remember babbling? Consonants. Bababa, mamama, papapa. Pag wala pang consonant, pag a, e, i, o, u, vowels lang, ang tawag doon cooing. Cooing at 2 to 3 months. Object permanence, favorite na tinatanong sa exam, 9 months. First words, walks without support. Malamang ilang taon to, nagsasalita na siya, naglalakad na walang support, probably 12 months. Okay? This reflex is elicited by sudden movement, loud noise. Okay? So I think nasa question sa isang mga quiz nyo yan. So pag biglang nagpalit yung temperature, biglang lumamig, okay, nagulat si baby, basically this is your startle reflex. Okay? Describe as symmetric extension, abduction of the fingers and upper extremities, followed by flexion and crying. This is your Moro reflex. Okay? Deficits in socialization plus repetitive behavior. Ano to? Autism or ADHD? This is autism, ASD. Ang ADHD, impairing levels of inattention, disorganization, hyperactivity, and impulsivity. So, wag pagpapalitin yung dalawa, very glaring naman yung difference nila. All right? Profuse, rice, watery diarrhea, voluminous diarrhea. This is your cholera. The drug of choice is either tetracycline or doxycycline. Alternative is azithromycin or cotrimoxazole for less than 9 years of age. Okay? Kasi yung doxy sa yung tetra, meron silang age na hindi pwedeng ibigay pag mas bata. Okay? Prolonged fever, abdominal pain, diarrhea, meningismus, rose spots. Anong sakit yan? Prolonged fever, tapos GI symptoms, tapos non-specific, nakakalito, may seizure, may carditis, merong ano pa ba iba? Nephritis, okay? This is your salmonella, okay? Salmonella. The drug of choice for salmonella that is fully sensitive and uncomplicated, you can actually give chloramphenicol. But empirically, if wala ka pang culture, we usually start with your third generation cephalosporins, ceftriaxone and cefotaxime, because they will cover for both your quinolone resistant and your severe typhoid. Bloody stool, tenesmus, pus, McConkey agar, xylose, lysine, deoxychocolate, or your SS agar. Ano to? Okay? Sabi natin, bata nagtatae walang dugo, rotavirus. Bata nagtatae na may dugo unless proven otherwise, this is Shigella. The drug of choice is ciprofloxacin. Okay? Other drugs, sabi ni Nelson's, pwedeng cefixime. Okay? Cefixime. Pero again, WHO tayo pagdating dito, the drug of choice is ciprofloxacin. Okay? Obstruction. May bara yung bituka. Okay? Again, ano yung mga question na tatanungin if you want to rule out obstruction? Onset. Pag early onset, baka may obstruction. Bilus ba yung vomiting? Pag bilus vomiting, baka may obstruction. Lumalaki ba yung tiyan? Saka hindi siya dumudumi. Pag lumalaki yung tiyan at hindi siya dumudumi, baka may obstruction. Okay? Okay. Currant jelly, paroxysmal pain. Sobrang sakit, pero in between, okay yung bata. Severe pain, knee flexing, flexion of the knee. Okay? Namimilipit sa sakit. Tapos may sausage-shaped mass. Ang description, you have a portion of your alimentary tract that is telescoped into the adjacent segment. This is your intussusception. On ultrasound, look for your donut ring or your target sign. Okay? Erythromycin used during neonatal period. Ito, hindi ko nabanggit to ng lecture. Okay? One of the risk factors for developing this disease is using your erythromycin. Kaya bawal yan sa neonates. Okay? It presents with postprandial vomiting. Meron kang firm, palpable mass. Ang shape ng mass, olive shape. This is your pyloric stenosis. On barium, look for your shoulder sign and your double tract sign. Absence of your ganglion cells, constipation, delayed passage of meconium. This is Hirschsprung's disease. On imaging, you can look for transitional zone or ano pa ibang pwedeng makita, bird's beak. Okay, bird's beak sa colon, sa baba. Biopsy findings, the diagnosis is your suction rectal biopsy. Finding is aganglionosis. Painless bleeding, ectopic, gastric, and pancreatic tissues naligaw na punta sa bituka, sa intestine. This is your Meckel's diverticulum. Remember your Meckel's rule of 2. Okay? 2% of the population, 2 years more common, 2 times more common in male. 2 years old is the age of presentation. The defect is usually 2 inches long, located 2 feet from the ileocecal valve, and you have 2 tissues, gastric and pancreatic. This rule does not apply to everyone. Okay? So please remember that. Abdominal pain radiating to the back, vomiting, and fever. Most common cause in children, trauma followed by viruses. In adults, iba. Usually stones, usually toxins, drugs, alcohol. Okay? This is acute pancreatitis. Amylase versus lipase. Sabi ko sa inyo, lipase lahat. Okay? For pedia, lipase lahat. Okay? Madaling tandaan, lipase lahat. Lipase ang mas specific, rises faster, remains elevated longer. Lipase, L longer. Lipase lahat. Okay? Most valuable serologic marker for acute hepatitis B infection. It is your anti-HBC antigen. Bakit? Meron siyang IgM, IgG. Siya lang yung nagpa-positive during the window stage, yung IgM. Okay? Nephrology. Sources of hematuria. Okay? Hematuria, ang cutoff natin for centrifuge urine is 5. Okay? Sources of hematuria. Pag T-colored, mataas yung protein at dysmorphic, malamang glomerular. Pag gross hematuria, gross blood, yung protein mababa at normal yung morphology. Pag sinilip sa microscope, yung mga red blood cells, hindi siya dysmorphic, normal yung morphology. This is lower urinary tract. Okay? HOHA, di ba? Mnemonics natin, HOHA. Pag HOHA, glomerulonephritis. Pag pale, nephrotic syndrome. Again, ang pinaka-importante is hematuria. When you have hematuria, think of glomerulonephritis. When you have proteinuria, ito yung pinaka-importante, think of nephrotic syndrome. Okay? One minute. All right. Kapag glomerulonephritis, your top differential in children is your post-strep GN. Remember, pyogenes. It's your strep pyogenes. Okay, other name, group A beta hemolytic strep. Infection from pharyngitis or pyoderma. I'll make a correction, guys. Sabi ko sa exam, kapag rheumatic fever, sore throat lang. Okay? Hindi tayo nagkakaroon ng rheumatic fever, sabi ko, kapag pyoderma. Actually, that is wrong. Okay? I'll make the correction. Pwede. Pwede pero rare. Okay? You rarely get rheumatic fever from pyoderma. Pwede pero rare. Okay? How do you document infection? Pag throat, ASO. Pag skin, your anti-deoxyribonuclease B. C3 level is decreased. Tatlo lang naman yung bumabagsak yung C3, PSGN, SLE, MPGN. Tatlong renal causes, renal insufficiency. Okay? And again, remember, between or among the three, si PSGN lang ang fully nephrotic ang presentation. Si SLE sa kasi MPGN, pwede siyang mixed nephritic nephrotic. Si PSGN, glomerulonephritis lang siya. C3 should normalize in 8 weeks. Otherwise, if hindi pa rin normal after 8 weeks, hindi na yan PSGN. Protein excretion and hypertension 4 to 6 weeks. Wag malilito. Okay? Dok, may proteinuria pala? Pwede, konti. Pero hindi ganun karami. Okay? Mababa lang. Usually +1, +2. Acute phase in 6 to 8 weeks. Hematuria is long. Pwedeng 1 to 2 years. Okay? Let's now go to nephrotic syndrome. Okay? Sa nephrotic syndrome, ang hahanapin is proteinuria. Sa dipstick, dapat +3 pataas. Okay? +3 pataas. Hindi pwedeng less than 3. Okay? But the more accurate measurement is UPCR or 24-hour urine protein. UPCR more than 2, 24-hour more than 40 kapag ang pinag-uusapan is BSA per hour or more than 3.5 grams total in 24 hours. The most common cause is minimal change disease. It responds to steroid 95% of the time. If non-responsive, you do your biopsy and probably you will get focal segmental glomerulosclerosis, okay? By virtue of incidence, okay? Pag minimal change na hindi gumaling sa steroids sa bata, malamang focal segmental yan. UTI manifests only with fever, vomiting, diarrhea, anything and everything under the sun. That is pyelonephritis. Does not cause fever, does not cause injury, that is cystitis. Most common organisms are your colonic bacteria, E. coli, Klebsiella, and Proteus. Most of them are ascending infection. The gold standard for diagnosis is urine culture. And the drug of choice, usually for outpatient management, uncomplicated UTI, is cefuroxime or co-amoxiclav. For complicated UTI, we start with our third generation cephalosporin, ceftriaxone. If there is Pseudomonas, if you're entertaining Pseudomonas, you add your amikacin or you add your fluoroquinolones. Okay? Microangiopathic, hemolytic anemia, renal failure, thrombocytopenia, RAT. Ano yung RAT? Hamburger, HUS. Hemolytic uremic syndrome, trigger. Anong pinaka-common na trigger na HUS? EHEC, enterohemorrhagic E. coli. Next, Shigella, Shiga toxin. Okay? Microangiopathic anemia, thrombocytopenia, renal failure, pero may neurologic manifestation, may fever, more common in adults. This is your TTP. Thrombotic, thrombocytopenic purpura. Acute loss of kidney function leading to rapid decline of GFR. This is the definition of acute kidney injury. And if you have kidney damage for more than 3 months or more, you call that chronic kidney disease. Sorry, kailangan mag-post. Okay, tuloy tayo. Hematology and oncology. Anemia, okay? Anemia with increased reticulocyte count, this is the expected response. Think of hemolysis or hemorrhage, okay? Anemia with decreased reticulocyte count, think bone marrow pathology. If normocytic, then probably there's bone marrow damage or decreased stimulation. If micro or macro, think of maturation disorder. Ano yung mga yun? IDA, thalassemia, folic acid deficiency, and vitamin B12 deficiency. Okay? So yun yung mga maturation disorder. Walang tama yung bone marrow pero hindi sila makapag-produce ng red blood cells for whatever reason. Okay? So again, remember, dapat pag may anemia, dapat tumaas yung reticulocyte count. Pag hindi siya tumaas, pag bumaba siya, think of bone marrow pathology. Microcytic anemia, our mnemonics is CLITS. Okay, chronic disease initially is normal, but eventually becomes micro. Okay, lead, IDA, thalassemia, sideroblastic. Macrocytic, B12 or folic. How do you differentiate? B12 has neurologic symptoms, folic does not. Most common cause of anemia in infancy and childhood is iron deficiency anemia. In IDA, your TIBC is increased versus in chronic disease, it is low. In IDA, your red cell distribution width is increased, meaning the sizes are varied. May malaki, may maliit, may malaki, may maliit. Versus thalassemia, your RDW in thalassemia is normal. Okay? So yan yung mga clues on how to differentiate the two. Okay? Okay, sige. May tanong tayo dito. Good evening, Doc. Wondering how to differentiate ASD. So I hope we're talking about autism spectrum disorder versus GDD versus intellectual disability. Okay? Sige. Different terms, okay? Usually, ang nalilito yung mga students, yung ASD, Autism Spectrum Disorder, saka yung Global Developmental Delay. Okay? Kasi pag sinabing Global Developmental Delay, guys, pag sinabing Global Developmental Delay, you have delays in 2 or more spheres. Ano ba yung mga sphere natin? Motor, tapos language, tapos sa language may receptive saka may expressive, okay? Tapos motor. So fine language, receptive, expressive, tapos motor. Pag 2 or more yung delay mo, 2 or more spheres, ang tawag doon GDD. Bakit nalilito? Nalilito yung mga students kasi sa autism spectrum disorder, common din yung GDD. Okay? Technically speaking, yung mga severe, yung may mga autism, may mga ASD, pwede silang magkaroon ng GDD. Pwedeng part siya ng ASD. Okay? Very common ang language delay sa kanila. Very common ang intellectual disability sa kanila. Okay? However, what clinches the diagnosis of autism? Sa autism, kailangan yung spheres na deficient dapat present sa kanila. Ano yun? Dapat meron silang differences, dapat meron silang tawag nito. Dapat meron silang deficit in communication and interaction, and dapat meron kang restricted repetitive behavior. Okay? So, kapag linabas sa exam, may GDD yung pasyente, pero meron din siyang mga deficits in communication, interaction, tapos meron siyang stereotypical behaviors, yung mga repetitive, naglilinya ng kotse, naglilinya ng train, mas magandang sagot yung ASD. Kasi technically, it's a bigger umbrella, pwedeng nakapaloob doon yung GDD. Malinaw? So, pwede kang may ASD na may GDD. Okay? Kasi kung GDD lang yan per se, usually wala yan yung mga stereotypical behaviors. Usually, wala yan yung mga walang eye contact. Wala yan yung mga hypo or hyposensitivity to your sensory inputs. Okay? Yung intellectual disability, ID, it's actually just the new term for MR, for mental retardation. We no longer use the term mentally retarded. So, ang clinical term dyan is intellectual disability. So, pag sinabing intellectual disability, ang mini-measure lang is yung intellect, IQ. Usually, it's the IQ. Okay? All right. So, hopefully, I was able to clear up that question. Okay? Management of anemia. Okay, management of IDA, you give your iron therapy. For thalassemia, folic acid, transfusion, and if pangit talaga, severe yung thalassemia, splenectomy. Okay? Alpha thalassemia has 4 subtypes depending on ilang focus or foci yung involved. Silent, mild, hemoglobin H, the more severe type, or high drops. Beta, dalawa lang, major or minor. Okay? Abnormality in spectrin, nawawala yung biconcave shape, resulting in splenic destruction. This is your spherocytosis. Siya lang yung sakit na usually mataas yung MCHC. Sa board exam, ang turo sa atin, pag mataas yung MCHC, think of spherocytosis. The test is osmotic fragility test. Hemoglobin S, susceptible to polymerization, nawawala yung flexibility. Ang nangyayari, nagkakaroon ng occlusion. Nagbabara yung red blood cells. Sickle cell disease. Kaya ang manifestation niya, painful vaso-occlusive crisis. Pag nagbara siya, sumasakit yung mga organs kasi namamaga, nawawalan ng blood supply, nagkakaroon ng hypoxia. Wilms versus neuroblastoma, nasabi na natin to. Both are 2 to 5. Renal in origin si Wilms, si neuroblastoma kung saan-saan siya pwedeng tumubo. Pero ang top 2 is adrenals and your sympathetic ganglia. Wilms does not cross the midline, neuroblastoma crosses the midline. Wilms dahil renal, konti lang ang associated symptoms, hematuria, hypertension. Neuroblastoma, sandamakmak, iba-iba, nakakalito. Okay? Metastasis, Wilms is lungs, neuroblastoma is bones. Diagnosis, important kay neuroblastoma, BMA, urine VMA, and HVA. Management, pretty much the same. The most common malignancy in children is leukemia. Among your leukemia, it's ALL. On peripheral blood smear, you have pancytopenia and hypercellularity versus aplastic anemia where you will have hypocellularity. PE findings in ALL, signs of infiltration. In aplastic anemia, there are no infiltrative signs. That's how you differentiate the two clinically. Okay? Ano ba yung signs of infiltration? Okay, ano yung mga signs of infiltration? Lymphadenopathy, bone pain, organomegaly. Bone marrow in ALL, blasts and hypercellularity versus in aplastic anemia. So AA is aplastic anemia. Fatty infiltration and hypocellularity. Prognostic factor, the best three would be treatment, age, and leukocyte count. Among the three, ang pinaka-importante, the most important is treatment. Site of spread, huwag kakalimutan, liver, spleen, lymph nodes. Anong difference? Spread is metastasis. Relapse is gumaling ka, tapos bumalik ulit yung sakit. Pag relapse, saan mo hahanapin? Bone marrow, central nervous system, and testicular relapse. Kaya usually guys, pag yung mga leukemic patients nagkaroon ng relapse, automatic yan, nagbo-bone marrow biopsy, saka naglo-lumbar tap to check for leukemic cells. Poor prognostic factors, less than 1, more than 10, lalaki, more than 50,000 ang WBC, CNS leukemia, and mediastinal mass. Again, inuulit-ulit ko yan guys kasi lumalabas palagi sa exam. Lymphoma, regional ang spread, bimodal ang age, this is Hodgkin. Most common in children and adolescents, systemic, kalat-kalat, may organomegaly, this is non-Hodgkin. Most common solid tumor are your brain tumors. So again, remember the sequence. Leukemias, which is ALL. Susunod is brain tumor. After brain tumor, susunod si neuroblastoma, saka si Wilms. Okay? Bone tumor, metaphysis, sunburst, spindle cell. This is osteosarcoma. Pag diaphysis at onion skinning, think of Ewing sarcoma. Okay? All right. Okay, so far, let's go now to neurology. Okay? Paroxysmal time-limited changes in motor activity and or behavior. Pwedeng motor, pwedeng behavior. Because of abnormal electrical activity in the brain, this is the definition of seizure. Predisposition to generate seizure, this is what you call epilepsy. But remember, bago mo sabihing epilepsy, you have to have 2 or more unprovoked, walang trigger, unprovoked seizure, and dapat 24 hours apart. If the initial seizure is limited to one part of the brain, we call that focal. If the whole brain goes into seizure sabay-sabay, we call that generalized. Okay? Continuous activity without regaining consciousness, more than 5 minutes. This is the operational definition of status epilepticus. Meaning, pag more than 5 minutes na yung seizure mo, kailangan mo nang mag-operate. Kailangan mo nang mag-intervene. Because pag more than 5 minutes na yung seizure, there's a very high chance that this patient will go into status. Ano bang definition ng status? 30 minutes. Okay? 30 minutes of seizure or either continuous na 30 minutes or pwedeng hindi continuous pero walang regaining of consciousness. Sorry guys, nawala tayo. Okay? So again, status epilepticus by definition is 30 minutes na continuous or kahit hindi continuous kung walang regaining of activity. Pero kapag more than 5 minutes na, that is what you call your operational. Kailangan mo nang mag-intervene. Okay? Blood workup for patients presenting with seizure, what do you check? HGT, hypogly can cause seizure. Hyponat, okay, calcium, magnesium, phosphorus. Blood gas to check for acidosis, and AED levels. Ano yung AED? Anti-epileptic drug. So if your patients are on maintenance, you have to check their levels. Baka kaya yan nagsi-seizure dahil bumabagsak. Okay? Lumbar tap. For patients with first febrile seizure, the cutoff is 18 months. Huwag nalilito. Okay, nalilito kasi guys sa Nelson's, actually sabi ni Nelson's in Western guidelines, kapag 6 to 12 months yung pasyente at nag-seizure siya, actually optional siya. So kunwari wala kang signs of meningitis, well yung bata, wala siyang previous antibiotic intake, pwede mo siyang hindi itap. Sa Pilipinas kasi guys, common knowledge na lahat ng less than 18 months pag first febrile seizure, dapat tinatap yan. Okay? The reason is, pag less than 18 months, mahirap sabihin based on your physical exam kung may meningitis yan or wala. Okay? So, Doc, ano ba talagang susundin sa exam? We have agreed, okay, that for top-notch guys and for the board exam, ang isasagot ng ating mga students is yung 18 months. Bakit? General knowledge. Okay? Lahat halos ng doktor sa buong Pilipinas, yan yung alam. Okay, bihira yung nagbabasa ng Nelson's, bihira yung sumusunod dun sa AAP guidelines na 6 to 12 months, bihira yun. Okay, so to be safe, to play it on the safe side, ang sagot natin 18. Okay, major risk factor for febrile seizure, age less than 1. If your fever is less than 24 hours, tas nag-convulsion na siya agad, and pag sobrang taas ng fever, there's a high probability na umulit yung seizure na yan. When to do LP? Ito. Okay, if less than 6 months with fever and seizure, or if ill appearing, any age, if with symptoms of concern, meron kang Babinski, meron kang clonus, meron kang nuchal rigidity. Sabi dyan, optional, if deficient in Hib vaccine or strep pneumo immunization. So again, this one is the guidelines from Nelson's and from AAP. This one is your PPS. Although outdated, I would advise you guys na pag sa exam, lumabas yung choice na 18 months, I would advise that you choose this answer. Okay? Meningitis, rare before 9 months and after 5. Febrile seizure, generalized, not more than 15 minutes, normal PE. Okay? Occurs only once in 24 hours. Ang tawag dyan is simple febrile convulsion, also known as your benign febrile convulsions, BFC. Okay? Kapag hindi pasok dito, kapag umulit siya, more than 15 minutes, may PE findings, then ang tawag na doon is complex febrile convulsion, CFC. The most common etiology of central nervous system infection in children is tatlo, NHS. Ang mnemonics, National High School. Okay? National High School. Neisseria meningitidis, H. influenzae, strep pneumo. Okay? Duration of treatment. Neisseria, 7 to 10. H. influenzae, 10 to 14. Strep pneumo, usually 14 to 21 days. Okay? Immediate management in patients with active seizure. Again, pag nasa choices yung airway, breathing, circulation, yun ang uunahin yung isagot. Yes, of course, you have to give your short-acting benzodiazepine. Drug of choice is midazolam or diazepam. But kung papipiliin, dalawa yung choices, diazepam or manage your airway, breathing, and circulation, the better answer is ABCs. Okay? CSF findings in meningitis. Pleocytosis, maraming cells. Usually, WBC yung mataas. Usually, neutrophils yung mataas. Elevated protein and decreased sugar. Okay? Should you do blood culture in patients suspected for CNSI? Yes, because 80 to 90% of the time, you can isolate the organism because pag tinanong kayo, usually tatanungin ng pasyente yan, Doc, saan ba nanggaling yung meningitis ng bata? 80 to 90%, hematogenous spread, blood infection. Okay? So usually from a distant site. Kunwari, nag-pneumonia yung bata, kumalat sa dugo, meningitis. Okay? The drug of choice for N-meningitidis is penicillin. Prophylaxis, you give rifampicin or ceftriaxone cipro pag mga mas matatanda. Diffuse adrenal hemorrhage, vasculitis, DIC. You see this as a complication of meningitis. This is what you call your Waterhouse-Friderichsen syndrome. Okay? In fulminant cases of meningococcemia. The most severe form of neural tube defect is myelomeningocele. All of the layers are affected, the skin, the bone, and the spinal cord. Okay? Prevention of neural tube defect, laging tinatanong sa exam, you give your folic acid, huwag pagpapalitin yung dosage, nilagay ko na siya dyan para hindi tayo malito. 0.4 mg once a day. Kapag may history of neural tube defect, 4 mg once a day. In microgram, that is 400 and the other one is 4,000. So please write that down. Please memorize para hindi nyo mapagpapalit. Seizures, mental retardation, shagreen patch. Okay, periungual fibroma, candle dripping on imaging. This is tuberous sclerosis. Kapag cafe au lait macules, axillary freckling, associated with optic glioma, and ang problem is nasa chromosome 17, think of your neurofibromatosis. So may diagnostic criteria. Please balikan sa handout and i-memorize nyo yun. Okay? Let's go to pulmonology. Stridor, viral etiology. Pag virus, usually may prodrome. Hoarseness. And this one responds to racemic epinephrine. When you do your imaging, you see your steeple sign, which is a form of subglottic narrowing. This is your laryngotracheobronchitis. You have to differentiate it from epiglottitis. Epiglottitis is more toxic. Okay? More toxic. It is bacterial. You need antibiotics. Hindi gagana yung racemic epinephrine. In epiglottitis, ano yung nakikita natin? You see your thumbs up, thumbprint sign. Okay? So thumbprint. Most common foreign body in children is nuts. The top 3 organism for rhinosinusitis, strep pneumo, Moraxella cataralis, and H. influenzae, non-typable. The drug of choice for rhinosinusitis is your amoxicillin. Pwede pa rin, pwedeng amoxicillin. Okay, high dose amoxicillin. Management for acute bacterial rhinosinusitis, ayan, sinabi na natin, amoxicillin high dose or co-amoxiclab. Ragged tracheal air column, staphylococcus. Think of bacterial tracheitis. Drug of choice for pertussis, okay? Presents with paroxysmal cough, tapos tuloy-tuloy yung ubo, namumula na yung muka ng bata, at the end of the coughing, nagkakaroon siya ng expiratory whoop, okay? Ganun, kulang siya ng hangin. This is pertussis. The drug of choice is azithromycin. Wheezing, less than 2 years old with fever, and other household member with the same illness. Think of bronchiolitis. Okay? Baka hindi yan asthma, less than 2. Tapos may sakit pa yung mga tao sa bahay. Remember, not everything that wheezes is asthma, and not all asthma will wheeze. Drug of choice for asthma, it's your inhaled corticosteroid. For acute exacerbation, it's SABA plus inhaled corticosteroids. Okay? Dati, sabi ng Gina, SABA lang. 2020 onwards, bago na yung recommendation, guys. Hindi na tayo nagsasaba only, higher mortality and morbidity, higher hospitalization. Dapat palagi ng may steroids. Okay? Inhaled corticosteroids or oral, pero usually inhaled ang binibigay. Pneumonia with consolidation, think of strep pneumo. Pneumonia with air leaks and pneumatocyl, automatic staphylococcus yan. Okay? And right middle lobe syndrome. Pag nasa right middle lobe yung pneumonia mo palagi, hindi nawawala, may chronic cough, weight loss, and adenopathies, think of tuberculosis. X-ray pa lang, may differential diagnosis ka na. So please remember that. Consolidation, very common in strep pneumo. Pneumatocyl, very common in Staph aureus. Okay? Across all age group, pag tinanong anong pinaka-common na cause ng pneumonia, it's your viruses. And again, the trend in children, in pediatrics, pag ang tanong sa inyo, most common cause, at merong viruses sa choices, malamang viruses yan. Maraming sakit sa bata na ang number 1 etiology are viruses. Okay? Most common bacterial pneumonia, yan na yun, iba na yun, sinabi na niya sa inyo, bacterial, strep pneumo yan. Most common cause of ORT is rhinovirus. The drug of choice for PCAP-A is amoxicillin. The drug of choice for PCAP-C, depending on your immunization status. Pag fully vaccinated ka, pwedeng fully immunized ka, pwedeng ampicillin. Pero, pag fully immunized ka, pwedeng PenG. Pero pag hindi ka fully immunized, kailangan ampicillin to cover for your HIB. Okay? And again, when do you consider changing antibiotics? Kailan ka mag-step up if walang improvement in 48 to 72 hours. And this goes through not just for pneumonia, even in other diseases. UTI, okay? In general, ganyan yung trend. Pag walang improvement in 48 hours, re-evaluate. Pathogens should you consider in patients with pneumonia 5 years and above? That is your atypical pneumonia. Drug of choice, your macrolides, azithromycin, clarithromycin. Cutoff for PPD. Remember, in general, the cutoff is 10. Okay? So abroad, sa States, ang cutoff nila 10. Pero, if you have risk factors, ano yung mga yan? Immunocompromise, exposure, x-ray findings, or signs and symptoms. Pag may risk factors ka, 5 lang positive na. By virtue of being a Filipino, okay? By virtue of living in the Philippines, where majority are exposed to tuberculosis, most of the time, ang cutoff na ginagamit sa Pilipinas, 5. Okay? GON complex is composed of 4 things. Your pulmonary focus, regional lymph node, peritracheal lymph node, and localized pleurisy. Okay? And how many out of the 5 parameters should be fulfilled to diagnose TB? Dapat 3. Okay? Ano ba yung 5 yon? Exposure, PPD, signs and symptoms, X-ray, other tests. Okay? So exposure, PPD, signs and symptoms, X-ray, saka other tests. Ano yung mga other tests? Gene expert, TB culture, okay, IGRA, okay? Alright. Treatment, regimen 1 or regimen 2 lang yung kailangan tandaan for exam. Okay? Keyword, regimen 1, hindi kasama ang CNS, bones, or joint. Regimen 2, kasama yung CNS, bones, or joint. Pag TB of the brain, TB of the bones and joints, regimen 2 ka. Okay, so 2 HRZE, 4 HR for regimen 1, 2 HRZE, 10 HR for regimen 2. Hindi yan HRR, HRZE lang yan. 2 HRZE, 10 HR. Whether new or retreatment, as long as expert is sensitive or indeterminate. Or new cases na walang expert na nagawa, ito ang regimen. Most of the time, ito ang tatanungin sa exam. Okay? So, ito, for personal consumption lang to, ito rin naman yan, guys. Okay? Ito lang yung mas detailed na makikita nyo sa DOH 2020 National TB Control Program Handbook. Alright? Let's now go to rheumatology. Kawasaki, how many days of fever? Dapat at least 5. How many criteria? Dapat at least 4. Ano yung 5 yon? Namumula from head to toe. Namumula yung bata from head to toe. Conjunctivitis, rash, adenopathy, tongue, hand, and foot changes. Remember, for Kawasaki, dapat hindi vesiculopustular. Dapat hindi exudative. Dreaded complication is your aneurysm. What phase? During the subacute phase. Usually, after 14 days, because your acute phase is 10 to 14 days, subacute is around 10, 14 onwards. Okay? Treatment, you give your IVIG plus aspirin, dapat anti-inflammatory dose. Okay? So high dose aspirin. Laging tinatanong sa exam, when do you do your 2D echo? At diagnosis, after 2 to 3 weeks. If normal, repeat after 6 to 8 weeks. If abnormal, we repeat earlier. Persistent fever after 36 hours. Nag-IVIG ka na, naglalagnat pa rin. That is what you call IVIG resistant Kawasaki disease. Kaya anong gagawin? Isa pang IVIG. Pag hindi pa rin gumana, anong gagawin? Usually other modalities such as methylprednisolone. Gotron papule, heliotrope rash, myositis, okay? Abdominal muscle weakness, Gower sign. So these are what you call your dermatomyositis. These are your neurologic problems na may kasamang dermatologic manifestation. Kalimutan ko na yung general term. Balikan ko mamaya. Okay? So this is juvenile dermatomyositis. Papules, Gotron, heliotrope rash, myositis, proximal muscle weakness. Okay? Palpable purpura, abdominal pain, joint pain. Okay? It is the most common cause of non-thrombocytopenic purpura, meaning normal yung platelet pag chinek mo. This is your Hinoch-Schönlein purpura. Okay? IgA-mediated vasculitis of your small vessels versus Kawasaki. Kawasaki is medium-sized vessels. Ang Hinoch-Schönlein is small vessels. Okay? Treatment is supportive. Hindi lahat ng HSP nagbibigay ng steroids. But if your patient has severe symptoms, severe abdominal pain, or nagkaroon siya ng glomerulonephritis na pangit, then you can opt to give your steroids. But for most cases of HSP, it is supportive. Hindi ko talaga maalala yung term kung anong tawag dun sa group of diseases nitong mga to. Yung meron kang dermatologic plus neurologic manifestation. Message ko na lang kayo guys. Okay. Less than 16 years of age, meron kang arthritis. Okay? And your onset is defined kung ilan yung tinatamaan. Ang tawag dyan, juvenile idiopathic arthritis. Dati, ang tawag JRA, juvenile rheumatoid arthritis. Ngayon, JIA na siya. Remember, pag 4 or less joints, that is oligoarthritis. Pag 5 or more, that is polyarthritis. And pag may rash and fever, think of your systemic onset arthritis. Okay? Autoantibody production resulting in inflammation of basically the whole body, halos lahat ng organ system. Pero common sa skin, sa joint, blood-forming cells, blood vessels, and CNS. This is your systemic lupus erythematosus. The most sensitive test is your ANA. You use it for screening. But for specific, we look for your anti-dsDNA or your anti-SMIT. Anti-SMIT is only found in SLE. Please remember that. All right? Let's now go to cardiology. Right? Cardiology. Your closure of ductus arteriosus is usually 10 to 15 hours. This is the physiologic closure. The anatomic closure is usually 2 to 3 weeks. Madaling tandaan, 14. Okay? 14 hours is closure na physiologic. 14 days ang closure na anatomic. The most common acyanotic congenital heart disease is your VHD. The most common cyanotic is your TOF. TOF presents with delayed onset of cyanosis. Usually months na yan. Medyo malaki na yung bata. Pero pag early onset cyanosis, think of transposition of your great arteries. Okay? Systolic ejection murmur on the second ICS, right-sided enlargement. Pag right-sided tapos ejection yung murmur, think of ASD. Kapag left-sided tapos regurgitant, think of VSD. Okay? Ilan-ilan lang ang sakit na merong regurgitant murmur sa LLSB. Okay? Sa left lower sternal border. Ano lang yung regurgitant murmur na yan? Ilan-ilan lang yan. VSD, MR, saka TR. Okay? VSD, MR, and TR. If it is rheumatic, that is mitral regurgitation. If it is congenital, then probably that is VSD. Tricuspid regurgitation, very rare. Okay? Continuous machinery-like murmur, bounding pulses, this is your patent ductus arteriosus. Remember, TOF, kailangan alam natin because it's the most common congenital heart disease na cyanotic. Component is prove. You have to prove that you have a TOF. Pulmonary stenosis, right ventricular hypertrophy, overriding aorta, VSD. The most important lesion is your pulmonary stenosis, your right ventricular outflow tract obstruction, because your pulmonary stenosis determines the degree of cyanosis. And sa TOF, natitrigger tayo ng TET spell. Remember, what triggers TET spell? Catecholamine release and decrease in your systemic vascular resistance. Guys, ang daming nalilito, and I think I have explained or I will explain this in detail during my, if not mistaken, maybe bonus lecture yata or sa Pearls. Okay? Guys, para hindi kayo malito, huwag niyong pagpalitin yung SVR na systemic vascular resistance saka systemic venous return. Okay? Sa TET spell, ang problema natin is decrease in your systemic vascular resistance at increase in your systemic venous return. Pag pinagsama mo yon, natitrigger yung TET spell. So how do you address that? Baliktarin mo. You give your phenylephrine, your vasoconstrictor, to increase your systemic vascular resistance. Yung SVR na tinutukoy nyo dun is systemic vascular resistance. Again, decrease in your vascular resistance triggers the TET spell. To abort the TET spell, you want to increase your systemic vascular resistance. Kabaliktaran ang venous return. Pag mas maraming venous return to the heart, mas nagte-TET spell. Okay? So ang gusto mo is to abort the TET spell, gusto mo yung venous return mas konti. And that's why you do your knee-chest positioning. Okay? You give morphine to calm the patient. You give oxygen to address your hypoxia, and bicarb to address your acidosis. You can also give propranolol to address the spasm of your right ventricular outflow tract. Huwag mag-alala. Again, I will have a discussion, very detailed discussion on this para hindi kayo malito. Miscellaneous CHD. Early onset cyanosis, increased pulmonary blood flow, egg-shaped heart, that is your toga. Weak or delayed, hindi yan deleted. Weak or delayed or absent femoral pulses. Blood pressure is higher in the arms or in the legs with rib notching, think of coarctation. The typical location of your coarctation is the descending aorta distal to the origin of your left subclavian vein. Remember, for your rheumatic heart disease, you have to have 2 major or 1 major plus 2 minor. Okay? Required ang evidence of strep infection. And yes, pwede sa skin pero madalang. Major is joints, carditis, nodules, erythema marginatum, and Sydenham chorea. Arthritis is usually polyarthritis. It's usually migratory. Carditis, you see that in 2D echo or pwede ring subclinical. Okay? Pag sinabing subclinical, wala siyang murmur pero meron siyang findings sa 2D echo. Nodules, saan siya? Usually sa extensor surfaces. And again, Sydenham's chorea, this is the standalone criteria. Pag meron ka niyan, malamang rheumatic fever yan. Minor is frappe, fever, risk factor, arthralgia, prolonged PR interval, also known as your first degree AV block, and increase your acute phase reactance. Okay? In rheumatic fever, migratory polyarthritis, sinabi natin kanina, large joints, and very important, they respond to salicylates. Pag nagbigay ka ng aspirin, nababawasan or nawawala yung pain. The classic findings on auscultation, ano ba hinahanap? Usually sa rheumatic heart disease, mitral regurgitation. So MR, how does it present? Again, regurgitant holosystolic murmur on your left lower sternal border. Wala kang auscultatory findings, pero pag check mo sa 2D echo, meron. Yan yung subclinical carditis. Erythema marginatum, it is serpiginous erythematous. Never on the face, disappears pag malamig, lumalabas pag mainit. Sinabi na natin to kanina, the diagnosis of recurrent, wag malilito. Ito, first diagnosis. Dapat 2 major or 1 major plus 1 minor. Pag recurrent na, ganun pa rin, pero in the Philippines, in areas where there is high risk for rheumatic fever, okay? In areas na maraming rheumatic fever, 3 minor pwede na for recurrent RF. Not the first diagnosis, but for recurrent RF. How do you eradicate your group A strep infection? 10-day course of penicillin or 1 dose IM. Okay? Anti-inflammatory agents are also given, aspirin or prednisone. And for prophylaxis, these patients will go on a long-term journey of monthly injection. Okay? Kawawa. Eventually, masasanay na sila. Buwan-buwan, tinutusok yung puwet nila. PenG every 21 days. Okay? Dok, akala ko 28. Okay? Recent guidelines, 21 na guys. So, mas maikli na. Okay? So, remember the difference between your innocent and your pathologic murmur. Hindi natin dadaanan yan. Let's go to infectious diseases. Neonatal conjunctivitis, usually it's your gonorrhea, chlamydia, and pseudomonas. In older children, think of viruses. Adenoviruses, staphylococcus. Kapag may inclusion body, think of chlamydia. Skin infection in children, most of the time, it's either staph or strep. Okay? Itong batang to, nakagat ng insect, tapos kinagat niya, kinamot niya. Tapos kumalat. Nagkaroon na ng erythema at blistering. Tapos, ang predisposition niya is your periorificial area. Periorificial, sa paligid ng mga orifice. So, sa bunganga, sa ilong, sa umbilicus, sa puwet. This is your staphylococcal scalded skin syndrome, also known as your Ritter disease. Sa isang exam, wala yung choices, yung SSSS. Ang tanong, Ritter. Yun yung lumabas sa choices. The drug of choice is Oxa, if MRSA, Vanco, or Clinda. Again, if methicillin-sensitive, Oxa, if MRSA, Clinda, or Vanco. Viral exanthems, you have to differentiate this. Dapat automatic, dapat hindi na malilito. Nung med school student ako, litong-lito ako dito after ng lecture ni Dr. Ruby, ang dali lang pala. Cough, coryza conjunctivitis, rash at the peak of fever, cephalocaudal nagdedesquamate, that is measles. Shorter duration, you call this your 3-day measles. Cephalocaudal din siya, pero ang hahanapin nyo, posterior lymph node. This is rubella. Okay, measles, look for 3C. Rubella, look for the posterior auricular lymph nodes. Okay? Ilan lang ang sakit na pag nawala yung fever, saka lumalabas yung rashes. Pag nawala yung fever, saka lumabas yung rashes, this is roseola. Okay? Different lesions, different stages, all present at the same time. This is varicella. Slap cheek appearance, para siyang sinampal. Okay? It spares the palm and the sole. This is your fifth disease or your erythema infectiosum. Dengue fever. Okay? Look for thrombocytopenia, hemoconcentration, but these two findings, you see this later on and pag may complication. A lot of times what you will see would be leukopenia. Mababa yung WBC. Remember the warning signs for dengue kasi pag may warning signs yan, those are indication for admission. The pathophysiology is increased capillary permeability. Yung capillaries nyo guys, nagli-leak. Dahil nagli-leak, lumalabas yung plasma, kaya nagkakaroon ng hemoconcentration. Kaya nagkakaroon ng thrombocytopenia. Anong mas nakakatakot sa dalawa? Malayong mas nakakatakot yung hemoconcentration. Bihira kang mamatay sa thrombocytopenia. Ang nakakamatay is hemoconcentration. Pag malapot yung dugo, pwede siyang mag-shock. Okay? The first 3 days of fever, the best test is NS1. 5 days onwards, that's when you do your dengue blood, your IgM. Management is supportive, fluid and hydration and monitoring. Okay? AIDS, the vertical transmission can happen via intrauterine transmission, intrapartum, or postpartum. Ang tinatanong sa exam, timing of your tests. For infants born to HIV-positive mother, viral testing is done on the first 2 days of life, 1 to 2 months, and 4 to 6 months. Monitoring of your CD4 and CD8, you do it at 1 and 3 months, and then every 3 months starting at 6 months of age. So please remember these, okay? So these are your viral detection assays, HIV, DNA, or RNA, culture, so forth, and so on, okay? Parasitic infection, pinworm, the drug of choice is Pyrantel pamuit. Wuchereria, Brugia, okay, elephantiasis, think of diethyl carbamazine. Echinococcus granulosus, albendazole. Cestode, the drug of choice is praziquantel. Trematodes, it's praziquantel. Ascaris is albendazole, okay? Ang nakikita kong pattern dito, nung nag-aaral ako ng micropara, karamihan ng mga bulate, ang drug of choice ay praziquantel. Pag hindi nyo alam yung sagot, baka praziquantel yung magandang isagot. Okay? But in the Philippines, routinely, we use mebendazole or albendazole. And technically speaking, yes, covered din lahat ng mebendazole saka albendazole yung mga bulating yan. Okay? Pero sa exam, pag ang tanong, drug of choice, usually praziquantel. Okay? Endocrinology. Remember the pattern. Okay? In girls, nauuna ang telarc, bago pubarc, then growth spur. Tapos saka pa lang nagkakaroon ng menarche. In boys, it's gonadarch, tapos pubarch, adrenarche, nahuhuli yung growth spur. Mas naunang tumatangkad ang mga babae kesa sa mga lalaki. And very important numbers to remember, precocious puberty is 8 in girls, 9 in boys. Pag meron kang development of your secondary sexual characteristic before 8 or before 9, you call that precocious puberty. Delayed, on the other hand, in girls is 13, in boys it's 14. Okay? Other notes, telarc, sabi ni Nelson's 8 to 12. Menses happen 2 to 2.5 years after your menarche. After your telarc. Okay? So telarc muna, after 2 to 2.5 years nagkakaroon ng menarche or your menses. Sometimes even as long as 6 years. Okay? Your peak height velocity happens at SMR 2 to 3 in girls. Again, mas nauuna. Versus the peak height velocity happens at SMR 4 to 5 sa boys. Okay. Most common cause of hyperthyroidism in children, it's your autoimmune causes. Okay. This is what you call your Graves' disease. So again, kapag hyperthyroid sa bata, think of grave. Okay. And ano yung hahanapin nyo? It's your TRS antibodies. In Graves' disease, dahil hyperthyroid siya, what do you usually see? Increased T4 and T3, decrease thyroid stimulating hormone. Kasi nga, mataas na yung T4 sa T3. And again, for Graves, look for your TRS antibodies. The definitive management is your radioactive iodine ablation or thyroidectomy. Okay? Permanent complication, of course, is hypothyroidism. So pag tinanggal mo yung thyroid, kailangan mo magbigay ng thyroid supplementation. Management for Graves is PTU or metimazole. Pag pregnant, PTU ang mas magandang gamot. Okay? Most common cause of thyroid disease in children and adolescents. It is also autoimmune, pero sa Graves TRS antibodies, ito ang hahanapin mo, TPO, thyroid antiperoxidase. Both will present with goiter, pero si Graves usually hyperthyroid. Etong sakit na to usually euthyroid. This is your Hashimoto's thyroiditis. And I guess that was my last slide, guys. Thank you for listening. Sana marami kayong natutunan. Okay, shameless plug. My channel, my humble YouTube channel is nearing 5,000 subs. Guys, like and subscribe. Magpapamigay ako ng keyboard on the 5,000 sub. Okay? Maraming salamat, guys. It has been a very busy, wonderful, and fulfilling week. Sana marami kayong natutunan. Good luck on your board exam. All right?
Ayan, thank you so much, Doc Ian. Maraming salamat for that very comprehensive summary lecture. Meron lang tayong mga questions on the floor, Doc Ian.
Yeah, sure, go. I'll try to
Meron lang
answer
siyang
my
question. Clarifying lang daw po, what duration cut-off we should follow for status epilepticus? 5 minutes or 30 minutes?
Okay. Definition, okay? 30 minutes ang definition ng status epilepticus. Okay? Pag sinabing operational, okay, 5 minutes. Okay, anong difference? Again, duration, technically speaking, 30 minutes yan. Pag sinabing operational, kailan ka mag-i-intervene? Okay, so pag sa exam, duration ng tanong, ang mas magandang sagot 30. Pag tinanong sa inyo, operational, what is the duration of the operational definition? Yun yung 5 minutes. Okay? Kaya siya operational. Ibig sabihin, kailangan mong, isipin nyo, mag-operate. Kailangan yung kumilos, kailangan yung mag-intervene. Because studies have shown, if you have seizures lasting 5 minutes at hindi ka nag-intervene, there's a very high chance na tutuloy yan sa status. Okay? Pero technically speaking, status is 30. Okay?
Alright. Next question, sir. Best po ba na i-answer yung TEF so unable to pass NGT between EA and TEF if hiwalay po sila sa choices?
Sorry, Doc. Ano yung tanong?
Best po ba na i-answer yung TEF sa unable to pass NGT between, pag meron yata, Doc, unable to pass NGT, ang isasagot daw po ba nila EA and TEF? If hiwalay po sila sa choices. Kung halimbawa daw, Doc, may EA at saka
Esophageal atresia or TEF. Mas magandang sagot yung esophageal atresia. Kasi pag may atresia ka ng esophagus, hindi mo maipass yung NGT. Okay? Sige, wait lang. Can I flash another slide? Mabilis lang. Okay?
Sure, sir.
Flash lang ako ng slide. Okay? So, okay. So, these are your forms of EA with TEF. Okay? Technically, guys, hindi lahat ng esophageal atresia with TEF, hindi lahat yan, hindi ka makakapag-pass ng NGT. May isa. Tignan nyo yung type E. Yung type E, pag nag-pass ka ng NGT, tutuloy pa rin yan. Kasi technically, may fistula lang siya. Okay? Pero to answer your question, ano ba yung mas magandang sagot? Kunwari hiwalay, EA saka TEF, mas maganda yung EA. Kasi pag may esophageal atresia ka, okay, pag blunt, walang butas yung esophagus mo. Pag atretic yung esophagus, that's the time that you cannot pass your orogastric or your nasogastric tube. Okay?
All right. Next question, sir. Second to the last na. Best answer sa must-pass meconium po within 24 hours or 48 hours if both are in the choices?
If both are in the choices, depende sa tanong. Pag ang tanong is, commonly, kailan ba siya napapas? Commonly, most of the time, 24 hours. Pag ang tanong is limit, ano yung limit natin? Ang sagot, 48 hours. Okay? So, yun. So, kung ang tanong sa inyo, Meconium is commonly passed within how many hours? Ang sagot, within 24. Pero pag ang tinanong sa inyo, limit, kailan ka mag-iisip ng Hirschsprung? Ang sagot, 48. Okay?
Thank you, Doc. Ito pa.
Ay, okay. Hindi pala ito sige, maganda tong tanong na to. Sabi guys, yung Kramer's chart daw, yung Kramer's chart. Okay? Hindi pala na-discuss. Dapat na-discuss to dun sa isang QR code. Anyway, sige. Kramer's chart, it's used to estimate your bilirubin level. May number na nakasulat dun sa drawing sa handout nyo. 5. Okay? 5, 10, 15, 20 lang yon. Okay? So 5 sa muka, 10 pag umabot sa nipple, 15 pag umabot sa umbilicus, 20 pag umabot sa tuhod, more than 20 pag umabot sa palms and soles. So, di ba may number dun sa handout? 5, 10, 15, 20. 1, 2, 3, 4 yung number dun. So, yung 1, 2, 3, 4 na yun, 5, 10, 15, 20. More than 20. Okay?
Alright. Thank you, Doc. Doc, according to the summary lecture po, ang ARF, 2 major or 1 major plus 2 minor. Pero sa handout yata, more than 2 major or 1 major plus 2 minor.
Rheumatic fever. Tama? Rheumatic fever. 2012. 2 major, 0 minor, or 1 major, 2 minor. Yun yung tama.
Yes, siguro hindi yung more than 2. More than 2 major. Malamang 2 major lang yan. Araw
2 major, 2 major, 0 minor, 1 major, or 2 minor.
Yes.
Okay.
Ito, Doc, last na. When is ICS plus formoterol more preferred than SABA as reliever, controller, and vice versa, Doc? Ang SABA ba reliever? Ay, controller?
Okay. Yung bagong guidelines ngayon, wala nang SABA na standalone. Okay? So, para yun na lang isipin natin. Dati kasi, SABA lang. Okay? Tapos, nagdadagdag ka lang ng controller pag, maintenance. Ngayon, even for reliever, ang nire-recommend na nila, ICS na. Okay? ICS plus or minus SABA. Baliktad na ngayon. So, bihirang-bihira na tayong gumamit ng SABA alone. So, hindi na uso yung sumusundot ng SABA. So, if ever, ang sabi ng guidelines, kung magsasaba ka, dapat may kasabay na ICS. Okay? So, in adolescents and children, 5 years old pataas, mas preferred na yung ICS plus formoterol. Okay?
Yeah, Doc. Ito last na, guys.
Very tricky yung asthma na yun.
Parang biglang dumami yung mga tanong nila.
Ang dami nga sa chat group eh. May time limit ba tayo dito, Bay? Pero
Sir,
okay lang sa...
Very important kasi na maka-interact din ng mga students yung mga
Yeah.
nila.
I really appreciate
So,
it.
pagbigyan natin. Sige, Bay. Sagutin
go.
mo lang.
Okay, Doc.
Oh,
Clarify lang po on PCAP classification. What to choose po if example, PCAP C and may high risk sa other choices?
Okay. Clarify lang po. Pickup classification. What to choose if example pickup C and... What do you mean may high risk sa other choices? For example, pickup A, B, C tapos high risk, ganun?
Siguro,
Tama ba?
parang ganun, Doc. Testmanship ang tanong yun.
Ang hirap sagutin kasi depende yan kung ano yung ginagamit ng examiner. Okay? Kasi actually hindi na ginagamit yung pickup A, B, C. Ngayon parang risk classification na lang eh. So parang dalawa na lang ngayon ang pickup. Ang pickup na lang ngayon is moderate, low risk or high risk na lang. Tapos under high risk nandun na yung C saka D. Okay? So depende siguro. So ang pinaka-common knowledge pa rin is yung PAPP 2020 guidelines. So ang pickup C sa PAPP 2020, siya yung may mga retractions, ganyan. Siya yung may mga desaturation. Ang difference niya sa pickup D, yung very severe pneumonia, yun yung merong grunting, may respiratory failure, saka meron siyang supraclavicular retraction. So, tignan nyo kung ano yung parameters na tinatanong, tapos doon kayo magsagot. Kutsa medyo malabo yung sagot ko, parang hindi natulungan yung estudyante. Mahirap kasi wala yung tanong eh. Better siguro kung merong specific question to. Okay?
Yes. Ito, Doc. Hi, Doc. Medyo confused po sa ALL. Acute lymphocytic or acute lymphoblastic leukemia po yan? Ano
Pares
po?
Pares lang.
Same
Lymphocytic-
banana Q, guys. Same banana Q. Sometimes it's turon. It's ALL is the same. As foreign body, most common foreign body ingested po, coins or nuts?
Nuts. Mas common ang
Talaga to? Nuts.
nuts. Okay. Foreign body na ingestion, mas common na ang nuts. Lalo na pag aspiration. Okay?
Mm.
Kasi yung nut kinakain talaga eh.
Okay, yes, correct.
Bihirang-
Hindi
bihirang
siya
bihira,
boring.
yung coin ano na lang yun eh, accident nilalaro lang yun eh. Mas common ang nuts. Okay.
Okay.
Saka wala ng coins. Masyado. Naka-Gcash na kasi mga tao eh.
Hindi na sila marunong mag... For asthma exacerbation, according to summary po, kay SABA ICS, pero sa discussion, SABA plus ipratropium. Which po i-follow?
Hindi madalang tayo nag-ipatropium sa asthma. Baka nagkamali lang yun. It's ICS.
Good evening, Doc. Clarify lang po kasi sa handout, increased SVR ang trigger ng TET spells. But sa lecture ni Dr. De Vera is decreased SVR.
So again, anong SVR ang pinag-usapan natin? So again, TET spell, kaya ayokong ginagamit yung SVR, nakakalito. Okay? Systemic vascular resistance. Ang trigger ng TET spell is decrease systemic vascular resistance and increase systemic venous return. Okay? So para hindi kayo malito guys, huwag niyong gamitin yung shortcut. Okay? Tignan niyo pag inaaral niyo yung flowchart sa kayong mga handout. Pag bumagsak yung systemic vascular resistance, magti-trigger yan ng TET spell. And part of the pathophysiology of TET spell is pag mataas yung systemic venous return nyo. Okay? So
last
again,
question. Ayan, sige Doc. Sorry.
TET spell again is decrease systemic vascular resistance, increase systemic venous return. Between the two, ang mas common na lumalabas sa exam is yung decreased systemic vascular resistance.
Meron dito, Doc, dalawang beses siya nagtanong. If surfactant maturity is achieved at 35 weeks po, why is it in OB po we only give antenatal steroids on preterm less than 34 weeks for lung maturity? Hindi ko alam, Doc, kung sa'yo ba ito itatanong or sa akin.
Parang ikaw yata doon ka mas maganda sumagot niyan.
Okay, steroids given at 34 completed weeks no sa mga older guidelines. So less than 34 and 6, you will give corticosteroids. Pero now until 36 completed weeks, so 36 and 6/7, ang 7 binibigay ang corticosteroids because they found out based on research no na decrease ang risk for neonatal respiratory distress when given at 36 completed weeks. So less than 34 weeks, ang sinasabi niya, less than 34 completed weeks, so pa 35. No? So depende kung anong subject, kung saan siya itatanong, basta nako-complete ang surfactant at 35 weeks. Okay? Yun yung
Can I add to that, Doc? Oh, so Doc, tama, sa bagong guidelines, 36 and 6, tama? Which actually makes sense because technically, sabi ko sa inyo guys, late preterm, 34 to less than 37. Kahit pa more than 35 na yan, pwede pa rin magka-RDS yan. Okay, so it makes sense. Pwede pa rin magka-RDS. So sinasabi lang sa libro at 35, mature na yung surfactant, pero it doesn't mean na hindi ka na magkaka-RDS. Okay, so pwede pa rin, pwede pa rin.
Tsaka, gumagawa pa rin ba ng surfactant? Yes. Okay, so next. Ito, Doc, nasaan na yung question natin dito? May primary CNS tumor po ba? Clarify, most common, primary CNS tumor po ba? Clarify lang po if medulloblastoma or astrocytoma.
Pwede kong balikan yan?
Yes,
Babalikan
mayroon yung mga most common na tanong.
Hindi ko maalala yung part na yan eh.
Yes,
Balikan ko.
depende kasi yan. Okay.
Ito may tanong dito, suctioning. Doc, sabi routine suctioning is not done because of risk and no benefit. May I ask, when would suctioning be appropriate to do if your patient has respiratory distress? Okay? So yung routine suctioning, we're talking about well, vigorous baby. Pero pag yung baby nyo may obstruction sa airway, pag yung baby nyo in distress, of course, you should suction. What are the risks of doing suctioning? Well, trauma, injury, pwede kang mag-inoculate ng infection kung hindi malinis yung process mo ng pag-suction. Worse, you can trigger your vasovagal reflex, pwedeng mag-bradycardia yung bata. Okay?
All right. So I think that's it for our summary lecture. Thank you so much, Doc Ian De Vera. Palakpakan naman natin si Doc Ian De Vera. Meron pang isang humabol. Last na talaga to, Doc, ha? Doc, ask ko lang po if sa MAS contraindicated talaga ang BVM. Di ko alam yung mga ano nila.
Meconium aspiration, bag valve mask. We're talking about meconium aspiration and ambu bagging. Actually, hindi siya contraindicated. Basically, ang sinasabi lang ng mga older guidelines, pag meconium aspirated yung bata, dapat mag-suction ka muna gamit yung aspirator bago ka mag-bag para hindi mo i-push down, papasok sa loob yung meconium. Kasi pag hindi ka nag-aspirate, pag hindi mo ginamit yung meconium aspirator tapos nag-bag ka ng bag, technically lahat ng meconium parang ipapasok mo papunta sa lungs. Yun yung mga old guidelines. Pero yung mga mas bagong guidelines, actually hindi na nga sila masyadong nag-advocate ng meconium aspirator. Sa NRPH, well, part pa rin siya dun sa resuscitation. Pero again, ganun pa rin. Mag-ambubag ka pa rin bago ka mag-intubate. Kailangan pa rin yun. Airway pa rin. Okay? So hindi siya contraindicated. Old notion yan. Yung hindi ka pwedeng mag-ambubag pag may meconium aspiration. Basically, ang sinasabi lang niya, tanggalin mo muna yung meconium bago mo ibag para hindi mo isaksak lalo dun sa baga niya yung meconium. Okay?
Correct. Ito na, Doc, last na. Doc, pwede po bang ma-explain yung mechanism of SIDS? Thank you.
SIDS.
I'm sorry po.
SIDS ba yan?
SID siguro. Ano ba yun?
Stunted infant death. Sorry guys, babalikan ko kayo dyan. Hindi ko kabisado yung topic na SIDS. Actually, if I'm not mistaken, parang idiopathic pa. Wala pa yatang exact pathophysiology yung SIDS eh.
Alright.
Yan.
Again, thank you so much, Doc Ian. Yun sa mga follow-up na question tungkol sa handout, please message Doc Broly with the screenshot. Kailangan may screenshot kayo ng mga tinatanong nyo para hindi na tayo mahirapan kung anong subject yan. Okay? So, and your details also. Thank you so much, Doc Ian. Maraming salamat. Palakpakan naman natin si Doc Ian, everyone. Maraming natutunan today. One of our best lecturers in Pedia. Okay, thank you so much, Doc Ian. Maraming salamat. Doc Broly, you have the floor for your announcements.
Thank you so much, Ian. Si Ian, tsaka yung wife niya, ang version natin ni Ding Dong at ni Marian Rivera. Papakita akong video sa inyo next time na parang ginaya nila yung video dati ng dalawa. Okay, so thank you so much, Ian. Hello. Sabi, break before I give the corrections and clarification. So get your main handout and I'll discuss. 2 minutes, everyone. See you.
Yes, and also prepare your quiz canton sheet. Okay, we will have your later. Thank you so much, Doc Ian, and ingat kayo sa biyahe pa Isabela. Okay, thank you so much. Yung mga ibang questions, again, for academic questions, please follow the format and send your screenshot nung handout. No? Pwede yung screenshot pag magtatanong kayo. Okay? Alright. So ano pa ba? So get your handouts, everyone, your Pedia handouts. Okay. Tomorrow, we'll have your intro to OBGYN at 8 a.m. via the portal. Pero ang mga BBs ko via Zoom tayo tomorrow, followed by breakfast with your MG. Alright, hintayin lang natin si Doc Broly. CR break, washroom break. Yung mga nasa Zoom pala natin, please make sure you follow the format also. MG means if you're my BB, if you're under my section, underscore, and then your full name. Okay?
So we'll start in 1 minute. Okay, get your main handout. Let's begin. Corrections and clarifications. So go to page 5, right lower quadrant. So dapat ang nakasulat doon, sorry, this is a misspelling, typo. Okay? Adducted and not abducted. So kindly change the spelling to adducted, not abducted. Page 5, right lower quadrant. Okay. Next, page 27, formatting error. So follow Nelson's 20th table, 198-7 or 21st na, version ng Nelson, table 225.6. Okay? For the treatment of typhoid fever. Next. So TB meningitis guide question, page 51, left lower quadrant, okay, versus your main lecture. X-ray shows hilar adenopathies. So correct your handout. So from Dr. Punumbayan, meningitis from bacterial causes will have similar CSF findings. The prolonged cough in this scenario points out more to TB than from other causes as opposed to the next case vignette in the video. So kindly make modifications to your handout. Doon sa guide question, page 51, left lower quadrant. Next. Page 65, left upper quadrant. Okay, kindly change your answer from, I think, bronchomalacia. Siguro yung nakasulat di ay osteomalacia. I think yung originally nakasulat dyan sa handout nyo. So kindly change that to tracheomalacia. So tracheomalacia dapat. Wheezes are heard, loudest over the trachea. Persistent wheezing never seems to go away. So correct the handout. Tracheomalacia dapat siya. Page 65. Okay, next. Dosaging of anti-TB drugs on page 69. Kindly write the following, okay, to reflect the latest updates in terms of the dosages. So for pyrazinamide and ethambutol, kindly change the numbers there. Do they ask dosage questions in the med boards? Rarely, guys. Okay, to the point we don't actually recommend that you memorize yung mga dosages. Never. Very rare that they ask that. Not in the past 3 years, definitely. Okay, next. Page 77, location of your ASD, atrial septal defect. Okay. Kindly change the one in their table. ASD is loudest at the second LICS or upper left sternal border. It's going to present with a mid to late diastolic murmur. Okay, next. Let's now go to the clarification. So tama yung nakasulat sa handout, but we have several students asking questions regarding certain concepts, nagkakaroon ng confusion. So let's discuss. Page 2, okay, regarding the APGAR score, there is confusion as to its use for need for resuscitation versus a rapid assessment. So quite a number of students actually message me regarding this one. So by the next batch actually, maglalagay na kayo ng detailed na yellow boxes to explain this portion. According to Dr. Ian, okay, again, the importance of the APGAR score is to assess the need for resuscitation. It does not dictate the steps for resuscitation. Okay, it is for quick and rapid assessment only. Next, page 11, right upper quadrant, regarding the Kramer's chart. So these are the values to remember. Face is 5, nipple line 10, umbilicus 15, knees 20, palms and soles more than 20. Okay, Kramer's chart used to estimate for bilirubin levels. So ito yung ano niyan. Next. Okay, RBCs in the centrifuge urine. Okay. Correct dapat is centrifuge is 10 RBCs as stated in the handout, page 33, right upper quadrant. So mali yung nandun sa video, okay? At this portion, okay? So eto dapat yung tama. Tama yung nasa handout ninyo, okay? Yung mali is yung initial part ng video. Next, so someone asked about the Lennox-Gastaut syndrome or Gastaut type, page 48. So according to Dr. Punumbayan, in Nelson's 21st ed, Lennox-Gastaut is primarily mentioned under severe generalized epilepsies, but it is also mentioned in passing under benign epilepsy syndromes. That's why you may see, Doc, parang may discrepancy. Okay? Kahit sa Nelson's meron. Okay? May discrepancy in a way because it's categorized actually under both severe generalized epilepsies but also benign epilepsy syndromes. Okay. Next. The use of diazepams in febrile seizures. So page 49 says that anticonvulsants is not recommended for febrile seizures. So according to Dr. Punumbayan, the continuous use of diazepam is not recommended nor its intermittent use to prevent recurrence of febrile seizure. Pero kapag may seizure sa ER, diazepam ang first line. So take note of this fine detail. Okay, next. Page 51, CSF findings. Okay. Doc, bakit may nakasulat doon na parang value na 50 to 80 tapos may value din na less than 28? So magkaiba kasi yung sources. One is from the guidelines, the other is from Nelson's. 50 to 80 is from one of the guidelines. Okay. The one in Nelson's is less than 28, yung nakasulat. So we will follow the one in Nelson's. We will also give a small note, okay, by the next edition ng handout regarding this one, kung bakit may difference. Okay, next. ICS, LABA, insufficient evidence on safety and efficacy, page 60, left lower quadrant. Doc, magkaiba. In the video, it was mentioned na less than 14. In the handout, mentioned less than 4. Okay, so ano yung tama? Okay, the one in the handout, so less than 4 years old. Okay. 6 years old for asthma. Okay, 6 years old in the lecture, 6 to 18 years old in the handout. Okay. According to Dr. Punumbayan, what explains this difference? The 2023 GINA main report states the same management for both age group, less than 6 and then 6 to 18. Tables in the handout then, okay, were included to emphasize important points. Okay, dahil kinuha yun from ang daming pages ng GINA na yan. Kaya may makikita kayo na may less than 6 siya, may 6 to 18 doon dahil yun yung pinagkuhanan ng tables ni ma'am, yung mismong GINA. So take note, parehas lang ang management, okay, for both less than 6 and 6 to 18. Next. Page 86, someone asked, Doc, chlamydia ba talaga parehas yung nandito for conjunctivitis or may iba pong organism for the second row? It's the same, it's chlamydia. Okay, red eyes, pus, inclusion bodies, scrapings, entered eyelashes, corneal scarring, and blindness. They all describe chlamydia. They both describe chlamydia. Okay, so tama yung nandun sa handout. Next, on the use of thiazides in treating nephrogenic DI. Nagtanong ng mechanism, page 98. So according to Dr. Ruby, okay, thiazides appear to induce a state of mild volume depletion by enhancing sodium excretion at the expense of water and by causing a decrease in GFR, which results in proximal tubular sodium and water reabsorption. Okay? So gagamit ka ng pampaihi, your thiazides, para makontrol mo ang nephrogenic DI, kung saan ihi ka ng ihi. So take a look at the mechanism kung paano nangyari yun. Next. That's it for the quality assurance portion, the corrections and clarifications. I'll see you tomorrow during the introduction for OBGYN. Okay? Take note, pakiusap ko lang everyone. Okay? Please never pirate our materials. Never live stream our video lectures or anything else. Okay? Report to us immediately those who do. Okay? You may seem that we're not doing anything. Guys, yung mga Discord servers kung saan yung ginagawa yung mga yan, nandun din kami. At nandun din yung mga kakilala namin. Okay? The lawyers are gathering evidences. Cannot hide. Okay? There are already witnesses. So, mag-apologize na yung mga dapat mag-apologize. Okay? Magsabi na yung mga dapat magsabi. Dahil pag na-involve na yung mga abogado, mas mahirap for you. Okay? Thank you so much. Doc Nina.
Thank you so much, Doc Broly. So those are your corrections and clarifications in the Pedia handout and lecture. All right. So for our next part, you'll now go to the Quizmaster session. So your Quizmaster for tonight graduated from the UST Faculty of Medicine and Surgery, the top 9 in the October 2022 PLE, magna cum laude of the BS Medical Technology also from UST, magna cum laude Doctor of Medicine in UST, and currently a pathology resident. Let's all welcome to the virtual floor, Dr. Christian Jirel Cosme. Hi, Doc. Good evening. Mag-hi ka muna, Doc.
Good evening.
Ayan, ang iba talagang face value ni Dr. Cosme. Nasa starstruck ako. Anyway, guys, before we start with the Quizmasters, let's just run down the questions para makasagot kayo. All right, again, this is what will happen. I will post the questions. I will give you 30 to 60 seconds to answer the question. After which, magpo-poll tayo pag si Dr. Cosme na yung magsasabi ng question. Polling, ilalagay nyo lang sa poll Alright? Yung mga nasa Zoom, ilalagay nyo lang siya sa poll. And later, no, sasabihin ni Dr. Cosme yung mga tamang sagot. And he will explain. Alright? Mhm. Alright. Can everyone see the slide? Ready na ba ang mga papel nyo? Alright. Question 1. For a while lang mga biya. Wait lang. Alright. Next question. Number 3. Question number 4. Question number 5. Question number 6. Question number 7. Question number 8. Question number 9. Last question. Five seconds. All right, that's it. So I hope nakasagot kayo mga B. All right, i-input lang natin yan sa poll, no? Again, let's all welcome our Quizmaster, Dr. Cosme. Hi, Doc. Good evening ulit.
Good evening, Doc Means. Good evening, everyone. Mag-present ako ng slides ko, Doc Means.
Go.
Tama na, Doc. Basahin ko yung question, tapos magsagot sila sa poll.
Actually, Doc, alam na nila yung questions eh. So mag-i-input lang sila.
Okay, so explain.
Flash mo lang. You can flash,
Okay,
just
sige.
flash it.
Okay. Wait lang. Okay. Okay, so question 1. A second-born 8-day-old baby is brought to the clinic due to jaundice. So the baby is essentially well and exclusively breastfed. So vital signs are normal. What is the most likely diagnosis? To submit your answers. Okay, so majority answered letter C, 44%, followed by letter A, 35%, letter B, 18%, letter D, 3%. Okay, so the answer is letter C, or breast milk jaundice. So what are the salient features in this case? So we have an 8-day-old baby. He is essentially well and he is exclusively breastfed. And the vital signs are normal, right? So in a patient presenting with jaundice, you need to take note of the onset of the disease. So if the jaundice occurred before 24 hours, it's most likely pathologic. So some examples would be EBO incompatibility. For example, firstborn child siya. kapag second born, pwedeng RH incompatibility. Kasi di ba in RH incompatibility, the RH negative mother gets exposed to the blood of an RH positive child, right? And the mother mounts an immune response to that positivity of the RH antigen. Okay? Kapag ano naman, merong history of prolonged second stage labor and there's no prenatal checkup, you might consider sepsis. And if there's history of maternal infection during pregnancy, a possible differential would be torch infection. Meanwhile, if the jaundice occurred after 24 hours, it's most likely physiologic, right? Kapag 2 to 3 days yung onset and the baby is normal naman, it's physiologic jaundice. It's called physiologic jaundice because the liver is still immature at this point, right? So hindi niya nade-deconjugate or nade-degrade yung bilirubin. Kapag 3 to 4 days naman yung onset, and breastfeeding lang yung exclusively breastfed yung baby. Sorry, if the jaundice occurred 3 to 4 days and mother supplements feeding with sugar water lang, there's less breast milk intake. It's called as breastfeeding jaundice. What if the jaundice occurred more than 1 week, like in the case, the baby is already 8-day-old, and the baby is purely breastfed or exclusively breastfed? It is breast milk jaundice. Okay, so here's a comparison between breastfeeding jaundice and breast milk jaundice. So how do we remember if anong mauuna? Breastfeeding jaundice may letter F, breast milk jaundice, it's letter M, right? So mas mauuna yung letter F kesa sa letter M. So ang onset ng breastfeeding is 3 to 4 days, while yung breast milk after the first week pa. So what contributes to the pathophysiology of breastfeeding jaundice? There's inadequate nursing or decreased caloric intake. So it's more of a mechanical problem, right? Kasi there's lack of calories, so there's less bowel movement. So as a result, you would not excrete or you remove your bilirubin from the intestines. So re-absorb lang sila. So there's increased enterohepatic circulation. Whereas kapag breast milk jaundice, you have high content of beta-glucuronidase in the breast milk, and it's responsible for deconjugating and reabsorbing bilirubin sa intestines. Kaya persistent yung jaundice mo kapag laging naka-breastfeed lang yung baby. The duration of breastfeed jaundice, short lang siya, few days, while breast milk jaundice, it occurs 3 weeks to 3 months. The management for breastfeeding jaundice is, of course, to increase the duration or the frequency of breastfeeding. Breast milk jaundice, you may stop for 2 days until the jaundice resolves. Okay? However, kapag nag-extend beyond 14 days yung jaundice and the isolated bilirubin na mataas is conjugated, it's called as neonatal cholestasis. And if direct bilirubin or conjugated bilirubin is elevated, it's always pathologic. Okay? Okay, next question. Okay, so majority, 67% answered letter A, followed by D, 14%, C, 11%, B, 7%. So the correct answer is, letter A. It's actually hypercalcemia. Okay? It's hypercalcemia, letter A. So what is DiGeorge syndrome? It's also known as congenital thymic aplasia. It is the most common T-cell disorder, and there's increased susceptibility of the patients to viral and fungal, tsaka protozoal infections mo. Ang affected dito is yung T-cells mo kasi you do not have a thymus, and the thymus is the site for maturation of your T lymphocytes, right? And the T lymphocytes are responsible for fighting your intracellular pathogens such as virus, fungus, and the protozoa. Okay? And the primary defect in this disorder is in chromosome 22, particularly the long arm of chromosome 22. So as a result, there's failure to develop of the third and fourth pharyngeal pouches. Kaya absent yung thymus and parathyroids mo. Again, the lab findings include decreased T cell or T lymphocytes, decreased PTH because you do not have parathyroids. So as a result then, the calcium is decreased kasi you do not have PTH. Okay? So here are the common manifestations of DiGeorge syndrome. So you can remember them by this mnemonic catch-22. C for cardiac anomalies or congenital heart defects. Letter A for abnormal phases or dysmorphic features. Letter T, thymic aplasia. Letter C, cleft palate. Letter H, hypo, not hypercalcemia. It's hypocalcemia. And of course, the primary defect is chromosome 22. Okay? Number 3. Okay. So majority answered letter A, IgA deposition, followed by letter C, 23%, then letter D, 19%, letter B naman, 16%. Okay? So the correct answer is, it's letter C. Letter C, defect in type 4 collagen. So this is Alport syndrome. So how do you know this is Alport syndrome? So there's the triad of hematuria or bloody urine, decreased visual acuity. So this could be due to lens dislocation and bilateral sensory neural hearing loss. So this is very classic of Alport syndrome. Okay? Why not IgA deposition? You have no history of cough, colds, or upper respiratory tract infection, diba? In IgA nephropathy, you should have a concomitant URTI that coincides with the hematuria. Kaya ang tawag natin dito, diba? Synpharyngitic because it occurs at the same time nung hematuria mo. Letter B, immune complex deposition. So we see this in PSGN or post-strep GN and SLE. Pero i-roll out natin to kasi the C3 level is normal. And we all know that in PSGN and SLE, the C3 is low, right? And in PSGN, you should have a precedent history of URTI, diba? Dito, wala siyang history na URTI. Letter D, why i-rule out natin to? Kasi in Goodpasture syndrome, there should be hemoptysis and severe respiratory distress in addition to hematuria. Okay, so answer is letter C, defect in type 4 collagen. So if you encounter Alport again, I want you to remember this illustration. So this is some male or a boy because Alport commonly affects male. And on the shirt, you have XD. So this means that it's the most commonly X-linked dominant disease. And the mutation, again, is in the type 4 collagen or the basement membrane of the kidneys, right? And remember this phrase, can't see, can't be, can't hear a B. You can't see kasi you have lens dislocation. Can't be, you have hematuria or renal insufficiency, right? And can't hear a B because of sensory neural deafness. So this is like the phrase of Reiter syndrome, right? Or reactive arthritis. But in reactive arthritis, it's can climb a tree instead of can't hear a bee because you have arthritis in reactive arthritis. Okay. So another point to remember is on electron microscopy, the appearance of the kidneys is called to be basket weave or basket weave appearance. So paano ko ito naalala? Isipin mo, pupunta kang airport or Alport, may dala kang basket, okay? You'll be bringing basket to the airport. So here's a mnemonic for Alport syndrome, or also called as hereditary nephritis. Letter A, anterior lenticonus. This is the pathognomonic sign for Alport syndrome. Letter A can also be for ACE inhibitors, kasi this is the only drug that can slow the progression of Alport syndrome. There's no therapy for Alport syndrome actually. Next is letter L for lens subluxation. Letter P, peeing of blood or hematuria. Letter O, ototoxicity or bilateral sensory neural hearing loss. R for renal failure. And T for thickening or thinning of the basement membrane. So again, under electron microscopy, the kidneys would appear as basket weave appearance. This is for Alport. So another buzzword for EM findings of the kidneys, when you hear tram-track sign or double contour sign, you think of membranoproliferative glomerulonephritis. So hirap paralahanin nito, di ba? Pero think of this, membranoproliferative. There are two combined words, di ba? Membranous plus proliferative. So there are double words. So double contour sign. Double contour, double words. Membranoproliferative. I hope that made sense. Okay. Next is spike and dome appearance. This is seen in membranous glomerulonephritis. Okay, spike and dome, membranous glomerulonephritis. But if there's effacement of food processes or podocyte effacement, and there's normal light microscopy, makita mo to sa minimal change disease. Minimal change lang siya, halos walang pagbabago. Kasi sa light microscopy, normal lang siya. And other term for this is lipoid nephrosis. Lipoid nephrosis. Okay? So what are the causes of renal failure that has decreased or low C3? It's PLM, post-strep GN, lupus nephritis, and membranoproliferative glomerulonephritis. So how do I take note of this? Go down C3 road, go down, meaning low C3, to reach PLM. Pero alam ko malayo C3 sa PLM. Pero ayun, down C3, meaning low C3, then PLM, post-strep, L for lupus, M for membranoproliferative. Okay, number 4. Okay, so majority answered letter B, 60%, letter A, 35%, okay? 2% C, 3% sa D. Okay. In this case, the answer is letter B, the thumb sign. Kasi this case is epiglottitis. So what can you notice here? The history is very rapid, right? The course is very rapid, 5-hour history lang. And there's drooling, muffled voice, and stridor. So these are signs of upper airway obstruction, right? So why not letter A, steeple sign? Kasi you see this in CRU or laryngotracheobronchitis. Letter C and D, pseudomembranous detachment and ragged air column. These are the X-ray findings of bacterial tracheitis. Okay, so how do we differentiate CRU from epiglottitis? CRU occurs in earlier ages, right? The stridor is more common here. And the pathogen is a virus, particularly para-influenza virus. And CRU is preceded by a prodrome. For example, the patient presented with history of fever, sore throat, cough, ganon. Pero kapag walang ganon, epiglottitis yun kasi very rapid siya. Severity of fever, low grade. And what's peculiar with CRU is the barking cough. And stridor improves with epinephrine. Epiglottitis, older age, less common ang stridor. It's caused by a bacteria. Remember, this is a bacteria. H. influenzae type B. Again, the course is very rapid. It's more toxic. And the severity of the fever is high. There's muffled voice and drooling. And there's no response to epinephrine. So ito yung X-ray finding kapag CRU or LTB, di ba? It's the steeple sign. It's like the church tower, yung patusok na ganyan. While kapag acute epiglottitis, it's the thumb sign kasi you have a swollen epiglottis here, para siyang thumb. Okay? All right. Next question. Okay. So 75% answered letter B. Letter A, 14%. Letter C, 9%. Letter D, 2% lang. Okay. So answer rito is letter B. Ciprofloxacin, right? So what's at letter A, metronidazole? Metronidazole, you give this in amoebiasis, right? And common misconception is kapag may bloody diarrhea, you give amibiasis. You give metronidazole, sorry, for amibiasis. But actually, amibiasis only consists less than 30% of bloody diarrhea. Letter C, why not tetracycline? Kasi in the history, there's painful bloody diarrhea. And we all know kapag cholera, the diarrhea is watery, di ba? It's described as rice water stools. Okay? And hindi hydration lang kasi according to the WHO, you need to give ciprofloxacin na if you're suspecting acute infectious bloody diarrhea. So salient features here, painful bloody diarrhea, constant urge to defecate, and meron kang elevated PMN sa stool and elevated WBC sa CBC. So this is very typical of shigellosis. Letter B, ciprofloxacin for shigellosis. Okay, so in order to establish an infection sa intestine, the Shigella bacteria crosses through the M cells of the Peyer's patches, and it will effectively invade the colonic epithelial cells on the basolateral side of the cell. Okay, so signs and symptoms include diarrhea, abdominal pain, and remarkable here is painful defecation and tenesmus. Tenesmus is the urge or the feeling that you want to defecate, but actually the bowel is already empty. Okay, remember tenesmus, shigellosis. So what do you expect in patients with shigellosis? Initially, they would present as watery, voluminous diarrhea, and it will evolve to frequent, small volume, bloody mucoid stools. Complications, familiar kayo rito, hemolytic uremic syndrome. This is due to the Shiga toxin. Okay? Seizures, kasi pwedeng 40% of patients may have neurologic involvement. And some represent sila as seizures. Okay? So how do we diagnose shigellosis? Presumptively, pwedeng meron kang elevated WBC sa stool mo, more than 50 to 100, fecal blood rin, and elevated WBC sa CBC. Definitively, syempre, culture pa rin. Culture of the stool or rectal swab. So you can manage shigellosis by giving empiric antibiotics such as cefixime, ceftriaxone, and azithromycin. But according to the WHO, right, ciprofloxacin is the most appropriate drug for bloody diarrhea, irrespective of age. Okay, remember ciprofloxacin. Of course, you would give hydration to prevent dehydration. And you may also opt to give zinc for the improvement of the gut immunity. Right? Number 6. Okay, medyo hati-hati yung votes, pero 39% answered letter D, 30% letter B, 27% letter A, 4% letter C. So the correct answer is letter D, the age. So if you're predicting the recurrence of febrile seizure, you need to take note of these risk factors: the age, the gender, and the duration of the fever, and yung level ng temperature niya. Okay? So here's the reason why, bakit yung age yung sagot. So major risk factor is age. If the age is less than 1 year, in our patient, di ba, 10-month-old lang siya. So may increased recurrence siya for febrile seizure. And the duration of fever should only be less than 24 hours. Less than 24 hours. And the level of temperature ranges from 38 to 39 degrees Celsius. Minor risk factors, nandito yung family history of febrile seizure, family history of epilepsy, complex febrile seizure, daycare attendance, male gender, and low serum sodium at time of presentation. Okay, number 7. Okay, so majority answered letter B, 46%, followed by letter A, 27%, 15% letter C, then letter D, 11%. Okay, so majority of you answered the correct answer naman. It's letter B. 10 years or until 21 years of age, or whichever is longer, right? So take note nyo to, yung pericardial friction rub, no murmurs na siya, and the unremarkable 2D echo result. Okay? So let's talk about on how we diagnose rheumatic fever, di ba? You would use the Jones criteria. Na-discuss nyo to kanina, yung major criteria. Mnemonic is Jones, right? Jones. J for joint swelling or polyarthritis, primarily involving the big joints. Okay? Remember the big joints. Letter O, let's assume this looks like like a heart. Kaya letter O, carditis. Letter N, nodules subcutaneous. These are painful subcutaneous nodules. Letter E, erythema marginatum. So ito yung serpiginous rash mo located on the trunk. Tapos namamula siya kapag exposed to cold, right? And letter S, Sydenham's-chorea. So this is the standalone criteria for rheumatic fever. The mnemonic for minor naman, it's FRAPE. FRAPE. F for fever, R for risk factor or previous RF for RHD. A for arthralgia. Arthralgia lang, meaning painful joints lang. Walang signs of inflammation, like in polyarthritis. Letter P, prolonged PR interval. And letter E, elevated acute phase reactants such as ESR and CRP, and elevated WBC. So, how do we diagnose rheumatic fever? You need a history of recent strep infection. So you could use ASO titers or swab culture, right? So in addition to the history of strep infection, you need to satisfy 2 major criteria or 1 major plus 2 minor. Remember this? 2 major and or 1 major plus 2 minor. So here's the duration of prophylaxis for people who have had acute rheumatic fever. So prophylaxis to para sa mga tao nagka-rheumatic fever na. Hindi ito to prevent to have rheumatic fever. Okay, so these patients already have rheumatic fever. So unang category, rheumatic fever without carditis. 5 years or until 21 years of age, whichever is longer. Next, rheumatic fever with carditis, but without residual heart disease. So the duration is 10 years or until 21 years of age, whichever is longer. And signs of carditis would include tachycardia, murmurs, pericardial friction rub, pericardial effusion, chest pain, ECG changes, and cardiomegaly. Next, if you have rheumatic fever with carditis and with residual heart disease or persistent valvular disease, the duration of prophylaxis would surely be longer, right? 10 years or until 40 years of age. Sometimes pwedeng lifelong yung prophylaxis mo. So signs ng persistent valvular heart disease kapag meron kang persistent murmur. Meaning hindi nag-improve yung murmur mo despite the prophylaxis given. And of course, 2D echo findings. So in the case, right, we have pericardial friction rub lang. Wala siyang persistent murmur and 2D echo findings. So in the boards, they like to ask about strep, about rheumatic fever, RHD. So here are the most commons of rheumatic fever or RHD. Most common heart valve involved in acute rheumatic fever, it's the mitral valve, right? Mitral valve. Most common valvular abnormality in acute rheumatic fever. Keyword here is acute rheumatic fever. So it's mitral regurgitation or insufficiency. Pero kapag most common valvular abnormality in RHD, rheumatic heart disease, it's mitral stenosis, right? Mitral stenosis. Magsistenose na siya kasi if the valves are damaged, they would undergo fibrosis, right? Kaya magsistenose na yung mitral valve mo. Okay, next question. Okay, very good. Majority answered letter C, 73%. Then, tig 9% yung A, B, and C. Okay? Obviously, the answer is letter C, left ventricular hypertrophy. So this is a case of tetralogy of Fallot. Kasi you have central cyanosis, squatting position, tas may murmur ka pa. Then, on X-ray, the apex of the heart is upturned. Very classic of tetralogy of Fallot. Okay. So in a child presenting with cyanosis, isipin nyo anong heart disease yung possible, right? Kapag cyanotic heart disease, nandito yung mga T's natin. The letter T's. T, tetralogy of Fallot. T, tricuspid atresia. T, TGA, or transposition of great arteries. T for TAPVR. T for truncus arteriosus. So patients present with cyanosis kasi there's right to left shunt, meaning yung blood na deoxygenated goes to the left side of the heart. And the left side of the heart is responsible for distributing blood right to the systemic circulation. Okay? Kapag a cyanotic heart disease naman, you have here ASD, VSD. VSD is the most common, PDA, and coarctation of the aorta. There's minimal or absent cyanosis kasi the shunt is from left to right, okay? Now we discussed tetralogy of Fallot. It's the most common cause of early childhood cyanosis. And again, the mnemonic here is PROV or PROVE. P for pulmonic stenosis or right ventricular outflow tract obstruction, right? So this is the most important determinant for prognosis, not the size of the VST. Remember, pulmonic stenosis or right ventricular outflow tract obstruction, sorry. Okay, next is letter R, right ventricular hypertrophy. Dapat right ventricle, hindi left ventricle. And as a cause, you push the left ventricle. Kaya on X-ray, mag-appear upturned yung apex mo or the boot-shaped heart. Okay, mukha siyang boot. Letter O, overriding aorta. You have an overriding aorta here na nasa taas ng VSD. Letter V, VSD. So in tetralogy of Fallot, diba, the child experiences that spells, right? Or cyanotic spells. So this is due to the exacerbation of the right ventricular outflow tract obstruction. And this is due to crying, fever, and exercise. So what's common here is that there's increased catecholamine release, right? There's increased catecholamine release. And by squatting, during cyanotic spells, mas nag-i-improve yung cyanosis nila kasi there's increased systemic vascular resistance and decreased right to left shunt. Imagine nyo, di ba, naka-squat siya. So you kink the major arteries here in the leg. So there's less venous return going to the right side of the heart. So less yung blood na lilipat from right to left. Kaya mag-i-improve yung cyanosis. Okay? All right, number 9. Okay, majority answered letter A, 70%. Then letter C, 12%. Letter D, 11%. Letter B, 3%. Okay, so majority got it correct. The answer is parvovirus B19, erythema infectiosum. So anong buzzword dito? Yung slap cheek appearance, right? Slap cheek appearance. VZV, makita mo to sa chickenpox, right? Or varicella. Human herpes virus 6, this is in 6 disease or exanthem subitum or Rosola infantum. Kapag Coxsackie or enterovirus, sa hand, foot, and mouth disease yun. Okay? So you might get confused with what's erythema infectiosum or yung 5th disease or ano yung 6th disease, right? Pero ganito ko siya naalala, kapag erythema infectiosum, di ba you have letter F? Sa 5th disease rin, you have letter F. 5th disease, FF. F, infectiosum, 5th letter F, FF. Okay? The causative agent is parvovirus B19. So this is the smallest DNA virus. Again, buzzword, slap cheek appearance. Very typical of parvovirus infection or 5th disease. And initially, the rash would appear maculopapular. Pero if the child is recovering na, the rash would become more lace-like or reticular in appearance. Parang ganito, lace-like appearance. And complications of B19 infection include transient aplastic crisis because the virus binds to the P antigen of the erythroid progenitors or the precursors of our blood cells, right? Another complication, hydrops fetalis or fetal death. So here are the most common viral exanthems. Measles or rubiola is caused by paramyxo. Remember the 3 C's, right? High-grade fever, then also the rash appears at the peak of the fever. And the rash progression, ano niya, from the head to toe, cephalocaudal. And pathognomonic sign is the Koplik spots. Koplik spots. Okay. Next is rubella or German measles or 3-day measles. So medyo nakakalito rin yung rubiola, pati rubella. Pero inaalala ko kay rubella, si Bella, German siya. Or Bella would go to Germany. Okay? Rubella, German. It's caused by toga viridae. The fever is low grade. Short course lang siya, 3 days lang. And similar to measles, yung rash, cephalocaudal yung progression. But what's peculiar with rubella, it's the post-auricular lymphadenopathy. And the pathognomonic sign is the Forsheimer spots. Forsheimer spots. Next, we have Rosola infantum or exanthem subitum or the 6th disease. Yung kanina, puro F, di ba? 5th disease, erythema infectiosum. Dito, puro letter S naman. Exanthem subitum, 6th disease, SS. Okay? It's caused by HHV6, 6th disease. So here, di ba, magkaka-fever ka muna ng 3 days, high-grade fever of 3 to 5 days. When the fever abates or nawala yung fever mo, then the rashes would appear. Okay? Common association rin kapag Rosola infantum, meron ding seizures. And pathognomonic sign is the Nagayama spots. Nagayama spots. So how do you remember these spots of these viral exanthems? So here's a mnemonic, MKGFRN. It's like giving an MK bag to your GF na RN. Okay? MKGFRN. Giving a bag to your GF na RN or registered nurse. Okay? Next, varicella or chickenpox, right? Varicella or chickenpox. This is caused by VZV. So here, the rashes are different, distinct sila. Parang constellation ng lesions mo. Pwedeng maculopapular rash, vesicular, meaning tubig-tubig, or pustular lesions. So they all appear at the same time. Okay? So yung volvet niya, usually the trunk muna, then it progresses to the extremities. Hand, foot, and mouth disease naman, it's caused again by Coxsackie and Entero. There are ulcers in your hands, hand, foot, syempre, and in the buccal mucosa or the tongue. Hand, foot, mouth disease. Okay. Last question. Okay, good. 79% answered letter B. It's the correct answer. Followed by letter A, 15%. C, 2%, D, 4%. Okay? So the correct answer is letter B or high RDW. Okay? So let's talk about iron deficiency anemia. It's the most common hematologic disease of infancy and childhood. It's also actually the most common nutritional deficiency worldwide. And it's most common in 9 to 24 months of age. Ito yung growing age natin. Okay? So they require more iron, right? The most common cause is poor dietary intake. And the most important sign is pallor. And pallor would only appear if the hemoglobin is already at 7 to 8 grams per deciliter. Okay? Take note, pallor is the most important sign. So here are the live findings of AIDA. So, microcytic siya, meaning small yung RBC mo. So there's low MCV. MCV of less than 80. So kapag magka-compare ka ng size ng RBC, kailangan may reference ka na lymphocyte. Particularly yung nucleus na lymphocyte. As you can see in this smear, mas maliliit yung RBCs compared to the nucleus of the lymphocyte. Okay? Hypochromic din kasi you have low MCHC. Hypochromic. So the RBCs appear very pale, right? The central pallor should only occupy 1/3 of the RBCs. Pero dito, parang more than 1/3 na siya. Okay? Alas ma-occupy niya na yung buong cell. Okay? Answer kanina, high RDW. Meaning there is variation in the shape or rather in the size, sorry. High RDW meaning variation in the size. Variation in the shape, it's poikilocytosis. Variation in size, it's anisocytosis. As you can see here, iba-iba yung sizes ng RBCs. Okay? And low retic count din kasi you have less iron to produce red blood cells. Okay, so it's very difficult to differentiate iron deficiency anemia from thalassemia by CBC and retic count alone. But yung smear, medyo mahirap siya i-differentiate. So you should perform iron studies, right? You should perform iron studies. Kapag sa iron deficiency, the serum ferritin is low, the iron is low, transferrin is increased. This is the binding protein of iron, right? And the total iron binding capacity is increased as well. Kapag thalassemia, normal to kasi wala ka namang deficiency ng iron mo, right? RDW, iron deficiency, high. Thalassemia, normal. Take note, it's normal. So they are both microcytic hypochromic. Kaya CBC is not enough. Retic count din parehong low. What I want you to take note today is the Menser index. It's a screening tool to predict if it's really iron deficiency or thalassemia. So you compute this by dividing MCV over RBC. MCV over RBC. Kapag greater than 13, it's iron deficiency. Kapag less than 13, it's thalassemia. Okay. Doc Nins, that ends the presentation na po. Thank you so
Ayan,
much.
thank you so much, Doc CJ.
Thank you, guys.
Palakpakan naman natin si Dr. Cosme. Maraming salamat, Doc, sa pagkuquiz sa ating mga students, no? So, ayos pa ba kayo mga B? Patingin nga ako ng mga scores nyo. Let's see the average scores. Average scores. Tingnan natin. Kung ano wow! So, average score is around 7. May mga naka 9. Okay. So, the average score is around 7. So, kung naka 7 kayo, good job! Alright, move on na tayo ng OB. Pero kahit na less than 7, mag-move on na tayo, no? Bukas, we'll start a new subject. Alright? So, okay lang yan. Kayang-kaya nyo yan. Alright? So, kung less than 7, habol lang sa pedia, mga B. Okay? Pag more than 7, congratulations. Pero kailangan, no, tuloy-tuloy pa rin ang pag-aaral. Okay? Kung alam mo na yan, meron ka pang ibang malalaman. No? Meron ka pang ibang matututunan. Wala namang lugi sa taong natututo. So, you always study. That's it. Thank you so much, everyone, for attending. No, our Quizmasters and our summary lectures sa ating mga nasa portal. No? Thank you so much. I will see you tomorrow. Sa mga BBs ko, I'll see you tomorrow. And dun sa mga nasa portal, we'll see you also tomorrow at 8 a.m. for Intro to OBGYN and your mornings with MGs. Okay, so bye everyone. Thank you. Sana masarap ang dinner nyo. Anong dinner natin? Okay. Bye!